Hello, welcome back again. So we're having a fantastic second day of our 3-day live surgery event. And for Professor Richard Harvey in Australia, it's the third day. So it's 8 p.m. in the UK and it's early morning in Sydney, Australia, where they're getting ready for surgery. So far, we have fantastic 2 days with surgeries from Spain. And today, we had Rick Carra and Professor Daniel Prevedelo performing craniopharyngioma from Wexner Medical Center, Ohio, in the USA. So I have with me my colleague, Louise Melia. She's a rhinologist from Bath in the UK. So how did you find the event so far, Louise? Do you enjoy it?
Yes, very much so. A shock. We've had great cases. So I was here for day one and we had an excellent selection of cases.
Give me a towel clip.
Showed us how to deal with, difficult cases, difficult fields to begin with. But then it was very interesting to see how the surgeons dealt with that. Gained a really good surgical field and then obviously dealt with the pathology that was at hand. So been very interesting and looking forward to the cases that we're about to see coming from Australia as well.
Yeah, great. And we have cases coming from Australia.
Let's go to the endoscope feed next.
Afterwards, we'll be joining eastwards.
Well, actually, leave the brain lab up. Leave the brain lab up.
Jaipur in India. So without further ado, I think we'll join the team in Sydney. And thank you to the whole team for taking all these efforts to join us today. So, Richard.
Okay.
Good morning, Richard.
Hey, good morning. Hold on 1 second. We'll just restart the endoscope machine. Just turn it off and on again. No, it's not clearing. So the white balance is not clearing. Just turn it off and on again. Yeah. Hey, so you should be able to see. Good morning. You should be able to see the scans up on the images. Let's get rid of any other feed other than just the brain lab scan, and hopefully you can see that.
Okay, correct. So we'll get the studio to connect to your feed, and then yes, we got your view. Fantastic. That looks interesting case.
Yeah. So this is a young 23-year-old girl. She's atopic and just has had progressive right-sided obstruction. And of course, all rhinologists and ENT surgeons will recognize this. She's got allergic fungal rhinosinusitis. And as it typically forms with the hyperdensities on the soft tissue view, expansile unilateral bone changes, and typically a young person with an atopic predisposition. And so she's really absolutely barn door classic AFRS case. When she saw me initially, her symptoms have been obscured by the fact that she's had long-standing She's had long-standing symptoms of allergy, and she's not only sensitized to mold, but also to dust mite. And so, when I saw her a number of months ago, the first thing I did is I started her on dust mite immunotherapy because she's actually got bilateral symptoms, this girl, but it is her right side that's worse, and the reason it's worse is because she's developed in an atopic individual, a secondary condition, and that's the AFRS. And that's a really important concept to remember, that many patients with AFRS have an atopic predisposition to start with, and that's, often masks their presentation. Now, it's pretty straightforward on the scan. Are there any questions, Ashok, before we go to the endoscopic feed?
Yes, I think the question comes to mind that over the last few years, have we seen any rise in these cases of fungal, even AFRS, after COVID?
You know what? I'm not the best person to ask for that. Here in Australia, we had so little COVID that, there were less cases of COVID than there were the natural respiratory viral event, flu season. So I'm just, and even though COVID is more severe than that, it just in terms of prevalence, it's just not so common in Australia. So I really can't comment.
Okay. Yeah.
How about you in the UK?
So certainly I've seen more number of cases over last in the post-COVID era than I've seen before. But of course, that's my anecdotal personal experience. What do you think, Louise?
Yeah, so I think we've seen an increased number in the more concerning fungal sinusitis. So we've had several cases come in that have had invasive fungal sinusitis, and I think certainly in India they noticed a significant rise in the number of invasive sinusitis post-COVID.
Correct. Yeah. Okay, so what's the surgical strategy?
Let's go to the endoscope feed, guys.
Yeah, sure.
And we're about to start here. Artery clip, thanks. Thank you. And we're going to do a timeout, guys. Just mute the audio for a second, guys. Can we?
Sure.
Ashok, what's interesting about this case as well is that it's unilateral, because quite often we see allergic fungal rhinosinusitis in its bilateral disease.
Exactly.
I don't know what your experience has been with that.
Yeah, I know that's commonly seen bilaterally.
Mm-hmm. And it can be really quite severe. We've had a few cases referred as query malignancies because they've actually had mucoceles and they've had, they've presented with visual disturbance, and it's been secondary to AFR.
Yes.
You got me back on?
Yes, we got your endoscopic view, and we'd like to know what is your preparation for this patient.
A couple of little things here.
Yeah.
Really important is to sort of acknowledge that the whole bed's at a sort of 15-degree angle.
Yes.
That's 15 degrees. And I think a lot of people, when they put their bed in reverse Trendelenburg, put it into 5 degrees and think it's the reverse. We're very comfortable. We usually operate at sort of 15 degrees reverse Trendelenburg. It's very common for us. And it's one of those things, like when you look at preparation for sinus cavities, there's little things you can do. If you use high-dose adrenaline, this is associated with about a half a Bozert score of field improvement in terms of bleeding. If you put someone in reverse Trendelenburg 15 degrees, this is another half a Bozert score. If you use bradycardic anesthesia, that's another half a Bozert score. And if you use tranexamic acid...
Sorry, Richard, I think your microphone is probably shifted away.
What's happened?
Yeah, so that's good. I think the sound quality is... Yeah, I can hear you well now, yeah. The sound was reducing.
Yes, I was saying, reverse Trendelenburg's half a Bozert score. Bradycardic anesthesia is half a Bozert score. Reverse Trendelenburg's half a Bozert score. And tranexamic acid given IV is half a Bozert score. And high-dose adrenaline's half a Bozert. So I think I named 4 things there. So, if you do all those little things, you get a lovely view, And I think we all know these things, but I don't, a lot of times when I see people practice, they don't put them into their daily routine, There's 12 RCT supporting tranexamic acid, numerous RCT supporting just simply using adrenaline or a simple non-selective alpha blocker. Very important for bradycardia rather than hypotension. So these are the sort of things that I use for the field. Now, look here. Here's the right-hand side. And you can see, very typical for AFS, right? It's got some polypoid degeneration coming. Now, to me, this is not the AFS here, right? That's the AFS, right? Can you see the sort of eosinophilic mucus?
Yes.
Yeah, so to me, this little thing here, which we're just going to shave up very quickly, is just allergic changes, in my opinion, coming off the bulla and uncinate. And here's some allergic change. That's not AFS coming off the middle turb. That's just an allergy change coming off that area. So now, when I'm going to approach a case like this, give me a ball probe, thanks. Look, sometimes I'll make an effort to see if I can see where the old uncinate is. But you know what? It often doesn't matter. And I'm intentionally going to go just to the back here. It's broken through here, so just give me a backbiter. I think a lot of us get fixated with the idea of wanting to find the natural ostium all the time. And it's so important sometimes just to not worry about that. And you want to find your anatomy. That's the most important thing. So the first thing we did there is just run along the superior edge of the inferior turbinate. So we've released the uncinate here. And then we'll take off the upper uncinate. Now, I always do the inferior uncinate first. Let's go an up-through cut, thanks, Lenny. And then I'll up-through cut, thanks. And then let's take off the upper uncinate. It still reminds me that a lot of people go for the upper uncinate first, and even though they know it's going to bleed down onto them, straight through cut, it's really not, in my mind, that's always going to make your inferior uncinate worse. And we have this general rule in sinus surgery that if we're going to do something in the sinuses, that we do something in the superior and posterior part of the sinus first before something anterior and inferior. Yeah, we're just shutting the sucker up there. It was sort of dropping out in this side there. Give me an up kerrison. So taking the inferior uncinate, take the superior uncinate. Now, it's really, I love the kerrisons. I saw Stamberger operate in Graz and he used the circular punch, but he used it in the same way. It's a really easy tool just to sort of quickly sort of munch away. So then when you come in with a shaver, and you can see I've got that classic crunch and gobble technique, right? So here we are now. There we are. We're going to open this all up. Just get rid of the polypoid change that's there. Get rid of the uncinate that I've just munched up. I'm not really trying to remove tissue with my forceps. And I can tell you, here's a tip for anyone doing cases like this. Don't fiddle around with a fungus right yet, right? You can now spend 40 minutes if you wanted to try to get that fungus out. That's not going to be very rewarding, in my opinion. The bulla is almost collapsed here. So what we're going to do is we're just going to find, there's the edge of the bulla here. So give me the backbiter. Oh, no, give me a kerrison, my apologies. Whatever's left of the bulla here, we're just going to nibble it away. So it's almost like going into the retrobullar area there. And once again, just sort of munching it up. There's a bit of mucus trapped in there. I just want to find the orbit. That's the only thing I'm interested in when I do a case like this. I don't really teach sinus surgery anymore about all the developmental anatomy. I really just teach it based on finding key landmarks. And one of the key landmarks here when you're doing an anterior fess is just to find the orbital floor. And sometimes can be a little tricky when it's a edematous. But there you go there. See that? That's orbital floor there. Yes. If that's orbital floor, then that has to be orbital wall. And if you're not sure that you're right, that's orbital floor for sure right over there. So give me the kerrison up. I can't quite see, in my mind, where the orbital floor becomes the medial orbital wall. And so I'll often then just nibble it a little bit more so you can really see, and I'll go with curette here in a moment. There you go. Perfect now, right? This is what I teach people to find. You see the floor of the orbit? That's medial orbital wall there. It cannot be anything else. So automatically as a surgeon, you know that that's the orbit right there. Let's go some patties, thanks. So now I'm going to stop here, right? Because I said to you, I'm not going to fiddle around taking this fungus out of the sinus cavity. Over the years, I've found that if you try to do limited ventilation type surgery for AFS and have a big maxillary sinus, you have a high chance that they'll have persistent mucus in their sinus cavity. In AFS, you really need to create a single cavity that they can wash out. And if you said to me as a researcher and scientist of the sinuses, he said to me, why is the left side not affected? The left side's not affected because on that side, mucociliary clearance is occurring, and it prevents fungal elements from making any prolonged contact with the sinus lining. And if there's not prolonged contact, then you don't get a reaction. And if you have prolonged contact, you get a reaction. And so something happened here on this right-hand side in the maxillary sinus where she had some mucostasis. I mean, it could have been any event, like a viral event or something else. And that's what set off then a period where she had prolonged contact in someone immunologically predisposed. Because that's a question I get asked a lot by people. Why does AFS occur unilaterally? This is the sort of thinking about it. So, Lenny, let's go with a artery clip now. So now we're going to do artery clip. Now we're going to do a modified medial maxillectomy. And this is really to make sure that we give this lady a really simple cavity. Now, things that you might want to see here, just as a way of interest, that we, let's shut that up. Peter Lee, do you want to grab that sucker and just sort that out? Thank you so much. So that's the nasolacrimal opening just there. See the little slit in the wall? Give me a sucker.
Yes.
Let's just have a clamp, guys. Just put a clamp on it.
That's the classic Hasner's valve.
Yeah, there it is there. So look, I'll try not to beat it up too much, but you can see what it is. So for most people, Hasner's valve is just this little slit opening in the side wall. It's not a hole in the top. that people see. Give me the artery clip now. Yeah, maybe a second one, like a needle driver, just to clamp it. Yeah, put a needle driver on that. Okay, yeah, sure. Okay, here we go. So we're going to put an artery clip on. Now, I like to just crimp it here. Give me a curved iris, thanks, just to help with hemostasis. So this section of the middle of the inferior turbinate, we're going to remove so we can expose the rest of the medial maxillary wall. And I just simply will amputate this section, and then I'll show you about raising a small, I like to preserve the inferior meatal mucosa as a small flap. Now, as you come down here, you can see the whole wall is slightly medialized. Now, as you get towards the back, there's no point leaving a really big back stump. I think if you do, it doesn't often function properly, gets maximally dilated a lot, and I'll just try to cut it off. But you don't want to cut it off so flush with the wall that you end up with, almost stripping it from the bone. You want to leave it, let's go with the Metzenbaum, thanks. You want to almost leave a little stump so you can bipolar the little artery that's in there. And normally, you can see the very end of it here. Let's see if we can actually just get down here. I think I almost got through it. There it is. There you go. Blakesy, thanks. Now we'll take it away. Okay, let's go needle point now. Next, thanks. I'll get you to get a clamp and put that on it rather than doing that. Okay, so here we are. This is the floor now. Yep, and I'll get you to grab it now and we'll get you to... Now, when I do a medial maxillectomy, you want to feel for the hard palate, soft palate junction, somewhere along here. And then we're going to make an incision really at 90 degrees to the area that we want to divide. And just really make sure we're on the bone. Yeah, you want to be right down. We're right on the bony junction here. Great. Now, up here, though, I'll get you to swap for me. Give me a wipe. Give me the sucker. Let's go. I want to show you. There's our nasolacrimal area. I'm not going to look with an angled camera. I think we can sort of see the slit area. And then on this one here, this is why it's called modified medial maxillectomy, because we're going to preserve the valve area. And so this incision then is at a real 45-degree angle. Can you see that? It's very different to the back incision. You want to come at 45 degrees. Let's go Cottle dissector now. There you go, great. And then we'll just throw a clamp on that when we're not using the sucker. Now, because I've made the incision already, it's very easy to raise. Now if the bone is very thin, actually it's good just to raise it on the floor first. So the floor is always a good one. If you're struggling to raise it, or the mucosa is thin or the bone's thin, just go to the floor first. And it should release entirely here, actually, because if the surgeon had connected all my dots correctly, we should have no problems. And unfortunately, this surgeon almost did that. Not quite. There you go. And then we'll fold that flap up in this direction here. And you can see how the 45-degree anterior incision really helps us to fold that out of the way. Let's go curette now, thanks, guys. I love this maneuver. This we call Jessica's punch. I don't want to do all of this with the drill, so we just punch in. You got to punch somewhere comfortable. Don't be working really anterior and posterior in my mind. Kerrison up, thanks. And then we'll just come through now with a Kerrison, and then we'll use a straight through cut, thanks. So you want to come in, obviously the bone's really thin here in this patient. We'll come then through with a through cut. And it's exactly the same technique. Make sure we have a 12 sucker here when we eventually get this guy open. Yeah, not right now. A 12 though. Yeah. Minji, can we get a 12 Fraser, thanks? Just disposable. Yeah, hopefully I'm going to reduce the pain of sucking fungal mucus out for everyone. I worked in the south of the US with Rod Schlosser, backbiter, thanks. And the amount of fungal material that I had to suck out during my fellowship was incredible. And I've really got an aversion now to sucking thick mucus out of sinuses. I don't like it to take too long. Here we go. So you can see how I'm going to remove that bone right up to our cut here. Now, I've seen lots of people describe this tuna saving, modified medial maxillectomy, nasolacrimal duct preserving. It's all of those things. That's why it's called modified. And how you do it doesn't really matter. But what you can't do in a modified middle maxillectomy, Ashok, in my opinion, it's not a big hole. One is not doing the drill, thanks. One is not doing this surgery for ventilatory reasons. Let's go 30,000 on the button. Thanks, Minji. No, 30,000. Thank you. We'll just make sure our irrigation's working. Yep. And so the goal of the surgery is to create a sinus cavity that doesn't collect mucus. This is easy to wash out. And so we don't want any sumps to form. If you leave a sump or an area where mucus forms, this lady, unless she's on prednisone, will end up getting a reaction because she'll have a long contact time with the fungal elements. And I don't normally give fungal immunotherapy for these patients. They don't need it for most of the part. If you just restore their mucociliary clearance, the sinus will come good, like the other side. Now, they are a little bit at risk, Ashok, I think there's a few publications to show that you're a little bit at risk of getting it on the other side, even if at some point in time. But I must admit, I'm not one yet of doing the other side, prophylactically or anything, I just try to just get it right. What about you? I mean, you're probably over the course of your career have seen people who come back perfectly normal side one time and then a few years later they get it on the other.
Yeah, yes. And there is argument by some that you can do at least mini phase type of procedure, uncinectomy, middle meatal antrostomy. But again, he said if it is not broken, why fix it? It seems perfectly normal on the other side in this case.
Yeah, I wouldn't even fiddle with it. If it's normal, I wouldn't even do. I don't believe doing a simple antrostomy in my mind protects you from sorting that out. And you'll see once again here, Ashok, I've really made a huge effort to not touch anything. Like I haven't touched haven't touched everything. I tell you, just as an efficiency as a surgeon, we'll just get rid of this little bit of posterior turbinate. It's much, much quicker if you just leave it all and get your opening right. And you can see I've almost got my opening right. To the point now, give me a ball probe, thanks. Let's take out the patty. And you'll see how much mucus is here, right? Mm-hmm. Look, from there, so imagine if you were a surgeon trying to remove this mucus plug from up here. Oh my gosh, I can tell you, Ashok, I've seen that, people do that, and it is the most painful thing to watch ever. So, I always promote the idea of get your opening right, then remove the mucus plug. Let's go a wash on a stick, Linny, on a long, thin curve, and we'll get our 12 sucker on. And you can see here that I'm still going to have to struggle. I'm sorry, I'm going to have to put everyone through mucus removal. But now, at least, give me another...
So you're almost going through the normal anatomy surrounding the whole disease, and then making it easier to remove.
Yeah, 100%. So let's give me another washout. So I find that a lot of the time you got to put a bit of a wash in to get the lump going. And I've even been known to take the 12 gauge sucker off the sucker and literally just put in the. Just want to pinch it for me. Go for it. Let it go. See, look, I got a 12 gauge sucker. And look at it, right? This is why, for all of those watching who thought I should have been removing mucus 5 minutes ago, and it goes to show, though, why we're doing this approach. If you did an antrostomy and spent half an hour trying to get rid of mucus, all you would have achieved is creating an empty mucus-containing cavity that's likely to recollect mucus in the next, little period after surgery, because they will sump and pocket mucus very, very easily. And this is, I think, why people used to, like I grew up in the days of Fred Kuhn, where he thought AFS was the worst condition ever and it was chronic. To me, AFS is the one condition that we can cure as sinus surgeons. It's eosinophilic, type 2, diffuse disease that we end up needing biologics for and everything else. Okay, I'm gonna do it. Pinch the sucker for me, please. Big Tilly Hankel. I have to resort to this sometimes. Doesn't always work, but let's have a look. Okay, hook us up, open up. Thanks, Lenny, open up. There you go. Hasn't put this 12 gauge back on. Oh my gosh. Alrighty, 12 gauge back on. Now, as I'm slowly removing this, the brain's trust of the panel, I'm open to any special techniques that people know of to remove mucus. I've never discovered one. My best one, I would say, is thick eosinophilic, a big hole, and make sure that you use the irrigation as much as you can, because irrigation sort of loosens up this tight attachment it has to the surface, I think. Let's go another irrigation. We might do a few more irrigations. I can see it coming loose here. And you can see with a nice big opening too, Ashok, I'm not struggling when it comes to, putting the sucker in and out. I see so many people sort of beat up the lining, when they're trying to suck something out and they're struggling. Have a nice big opening. You can suck it all out. It's a bit easier. Let's go that. Hey guys, don't worry about anything else here. Let's just go the wash and the stick, thanks.
Yeah, and with this technique, almost the whole of the mucus is coming out like a ball together. You can not dissect out from the edges, rather keep aspirating it. So when it is out, it will come out in total.
Okay, give me another wash and stick. And you can see it. I've loosened up the back, but this front wall has got diabolical amount of mucus in it. I wonder if I can come along the front wall. Oh yeah, getting there. It's always satisfying when it comes out. Just quickly grab it. Don't mess around. Okay, here we go. Wash and stick, thanks again. And I might try my little direct sucker approach again if I can loosen up this side wall. But once again, just a great demonstration of just needing to get your opening right first, Ashok, just so important. Yes. And this is also too, those of you in the audience who think, oh, can't you just get away with doing an antrostomy? This is the pathophysiologic process you're fighting. And this is why people who do little ventilatory surgery, on conditions like AFS, struggle sometimes, and they have patients who get recurrence or don't settle down even to begin with after the surgery. So I'll get you now to pinch the sucker for me.
And can I ask, so post-operatively, what regime would you put the patients on? Would you use oral steroids? Would you use steroid-impregnated rinses?
Okay, let's go. Yeah, so you have to use oral steroid for AFS. Yeah. You got to at least for some period of time suppress the condition, and I don't think you can do it with topical corticosteroid irrigations alone. And so they all go on oral steroids for a period of time. Usually something like 3 weeks, but you don't need a big dose. 25 milligrams max dose is all you really need to suppress, eosinophilic inflammation of the airway. Mm-hmm. So You don't have to give them much. There's no role for antifungals, in my opinion. I wrote the chapter 6 in EPOS 2020, which was all about fungal sinus disease. And you know what? There were some fascinating things that when I had to do the review of that, and I did even a couple of meta-analysis plots for things to really show that, being on things like antifungals makes no difference. This is a hypersensitivity condition. Now, whether or not you believe it to be a type 1 hypersensitivity, and so it's IgE mediated, I'm not really convinced that's the case, but it's an hypersensitivity. I mean, there are other types of hypersensitivity reactions like type 4 or delayed type hypersensitivity reactions. So I do think it's probably a bit more than just IgE mediated, and that's why drugs like omalizumab have never been the the sort of panacea for AFS or controlling it. And certainly I've got patients on biologics who have been given everything from benralizumab to dupilumab with AFS, and unless they get their sinus cavity cleaned out of all the mucus, it doesn't really help them. They have ongoing problems. So if you don't get out the mucus plug, just make sure the suction's on maximum, isn't it? This is where I'd like 2 striker units to help me suck out this. You can see, look, this is what you're fighting, right? This is AFS at its truest. Let's go this here. So I might have to just break it up here. Just grab it. Just grab a sponge and just get rid of it. It's not a specimen or anything. Certainly not at this point. Alrighty, here we go. So actually, this one unusually is going to sort of. Let's get Lenny a sponge so she can really grab this properly from me. She's just struggling with a little Ratex. Yeah. Thanks. Yeah, so I will give them some steroid, but corticosteroid irrigation still play a big role here. So, but you should be able to normalize the sinus cavity. And if the patient comes back to you at 3 weeks and their sinus cavity isn't normalized, you've got to be worried. If you haven't normalized them early on after surgery, then you've either left a whole lot of mucus in their cavity, or you're not giving enough oral prednisone to suppress the reaction, and they're just getting mucostasis again. It's just really wipe it for me. Don't worry.
So for a patient like this, Richard, what will be your post-op oral prednisolone regime?
Yeah. So 25 milligrams, for 1 or 2 weeks, 12 and a half, and then 5, maybe, something like that. Sometimes, if it's very localized, I might just give 25 for 2 weeks with a cold stop. You don't need to taper doses less than 2 or 3 weeks. I don't give small doses. I don't give really high doses for 2 or 3 days and then like a 10-day taper. There's really a lot of evidence now that that's not really how we should be using anti-inflammatories like prednisone. It just ends up exposing patients to subtherapeutic doses, and they don't need it. 2 to 3 weeks is a totally fine period to have someone on oral corticosteroid without worrying about a taper.
And any preoperative prednisolone, do you consider that?
I do sometimes. It depends how inflamed they are, but not normally though, actually. And I tell you why, Ashok, is that although I agree a little bit of pre-op prednisone can help their surgical field, I don't like. Can you pinch it for me? Yeah. Give me 2 seconds to focus here. Okay, and release. To improve their surgical field, it doesn't really help their recovery, and I'd rather limit their overall systemic corticosteroid use to the post-op period to help with overcoming their AFS. Does that make sense?
Yes.
Yeah. Although I completely acknowledge that if you give it, it will make things better. See, that's the shot everyone wants to see. See, just to show you that after debulking it, and just make it clear, I've attached the striker suction machine directly to the sinus, to the mucus ball there. And let's go back. We can do the 12 then, and we'll have one last look now. But that wasn't too painful. The pain was relatively minimal. let's go and do the rest of the sinus cavity then. You can send that piece off, Lenny. All formalin, thanks. Yeah, and that's a really important thing. Lenny just asked me, she said, do we send it off for formalin or for micro? Only formalin. Do never send AFS cases off for micro. You only totally confuse other doctors about what's going on. And so I think it's very important. Let's go to a 10, Fraser, thanks. This is not an infective condition. If you start sending off micro samples, you cloud the picture for everyone. And you might think our infectious disease colleague understand what we're doing here, but they don't. They really don't understand AFRS. The only doctors who really understand AFRS, in my opinion, ASHOC, are ENT doctors. I mean, I'm sure you've had that feedback. Immunologists aren't sure what to do with them, and respiratory doctors don't quite understand it. Now, here's something we're going to do that I do, and every time I do a medial maxillectomy, is that I'll really make sure that I dig out all the pockets. See how there's like a little pocket of mucus there?
Yeah.
Yeah, let's give me a curve sucker, thanks. That's very anterior. And that is an area that would cause recurrence. And so in people who have a well-pneumatized maxillary sinus, and you can see here, there's still like a little punny pocket happening.
You just wouldn't be able to reach that with an antrostomy.
Oh, yeah.
As you said, did that
miles away.
Yeah.
And you would have probably spent an hour trying to get the mucus plug out. And then you would have thought you'd done a great job because you were trying to stare in with a 70 scope and looking at what you'd done. And then the patient would have had grumbling, ongoing inflammation in the sinus cavity. And the surgeon, very commonly, this like 15 years ago, let's go the drill back on, would be dumbfounded by why it's not gotten better. But that this sort of phenomenon, what we're staring at now, is what's going on. Now, one of the things I'll do then, and we publish about this in dysfunctional maxillary sinuses, is that we really it's not a ventilatory condition. We're here to reshape the sinus cavity. That's what we're doing. We're trying to reshape it. So I'll drill this little bit of bone here. See this bit of bone? We call this Snidbong's wedge. It's just a little triangular bone where if you don't remove it, you can never see the front aspect. And then I'll drill off this whole side wall. And then we're going to carefully strip out the mucosa from this little pocket, and we'll get rid of it, like an obliteration. And I'll show you how we set it up at the end. We'll have some Surgiflow, thanks.
Is that the angled burr you're using, Rich?
Say it again?
Is that the angled burr you're using?
It's not actually angled, no.
No.
Like 15 degrees, yeah.
15 degrees, so, okay.
Anyone who knows me will know that I hate angled instruments and angled surgery, right? And you'll see here in a moment when we do the frontal, like what we do to make the frontal happen. Okay, look, we've got to go back to the smaller sucker, the 10, please. The 10 is what we need now. Let's stay with the 10. Big wash, thanks. Okay. Yeah, I only like the 12 when we need to do that really big area with all the mucus, and then let's not have a 12. 12's too big a sucker normally for sinus cavity. So here you go here, guys. Can you see this? So here's our little area. I've got a little bit more mucus here. And I'm not actually taking the mucus out now, guys. Can you see I'm taking the mucosa? I'm channeling my inner trainee and making sure I strip now, right? Okay, so this is here. This is the front wall. Let's go 90 curette, thanks. And this takes, if you take a bit of time to get the plane going, the stripping plane right, it makes it a whole lot easier. And you'd be surprised, look how deep some of these sinuses are, right? And I want to take it off so that I get rid of the very bottom sump. Let's go the curved long sucker on, thanks.
There's so many little nooks and corners, isn't it? It's not a flat cavity.
Yes, but it will be, Ashok. It will be at the end.
Yeah.
That's what we're going to turn it into. And we're going to make it a smooth bowl. There's a few little things we still need to do here. And this surprisingly is a big part of the surgery. A lot of people think medial maxillectomy is about making a big hole. It's not about making a hole. It's about creating a sinus cavity that has no area where mucus can collect and sump. What have we got on? Drill? Give me the drill and then we'll go to the shaver. And normally with a nice modified medial maxillectomy, you can do it all just with straight instruments. Make sure that there's no little areas. Okay. Give me the shaver, thanks. And now we'll shave that away. And at the end of the case, I'm going to leave it now, but at the end of the case, I'll show you how we fill it in order to actually make it smaller. Okay, here we go. And look, it doesn't take long. It's like a simple thing to do. It's really, what do we call it? An obliteration of the floor. If I can not suck up my flap, as you try to. Okay, give me 170-degree scope. This is for the audience, right? We'll show them the cavity. And you've got the curved sucker on. So I'll show you the cavity because we're going to finish there. But just for those of you who really want to see it. Now, you don't need to strip this mucosa any more than just the same level of the nasal floor. Anything higher than the nasal floor is sort of redundant in my mind as a concept. And we'll just make sure, there is a little tiny bit of bone there, so we'll just make sure that that front wall is good. 70. Just for those of you who want to see, a few times I'll put a 70-degree scope on. There you go. See that front wall? And look how there's even a little bit of mucus getting caught there, right? Is there a bigger one? Nope, it's fine. And this is the thing with curved suckers. Curved suckers are always so fine. And this is why you need to give prednisone. Because even though I've maximally removed everything, give me the shaver. Just give me the shaver. Yep. All right. Now, I don't feel like this is blocked or something. Look at that. Look how there's like the remnants. Let's go the wash on a stick, thanks. I'll go the 90, the small 90 on the wash, yeah. Let's see if we can wash that last little bit out. And you know what? If I can't wash it out, I'll see if I can get something else to remove it. And here we are, right? Even with my modified medial maxillectomy. Give me the 90 curette. Just got another wash on a stick, thanks. There you go. Oh my gosh. Everyone's going to say I should have looked with a 70. It was worth looking. After poo-pooing the 70 scope, it showed me that I haven't got everything out. Give me the wash on a stick. And you know what? That's that very most zygomatic recess, you know, where that's sitting in. That's not generally a big pocket. We'll get that now, I think, with the... So you've seen what I've done to the floor. That's really important. Look at that, and that's just the polypoid edema, and a bit of mucus sitting in there. There's our mucus. Oh my gosh, right? And then I think we're good. That might be a bit of, that's like, look at that, guys. Can you see that, Ashok? It's mucus in the mucosa. Can you see that?
Yeah.
Yes.
That's why you fail, right there, right? And so, let's see if we can shave all that off, right? That's such a diabolical situation, you know, for patients to have. Shaver. Doesn't always work, guys, so. Look at that though, right? Totally worth getting all that out. Oh my gosh. Okay. I can't possibly bear to operate with a 70 any longer. Give me a 0. Give me straight sucker. 10, thanks. Let's go big wash, thanks. That's what you were doing before, Peter Lee, weren't you? Yeah. Fair enough. Good call. Oh my gosh. So, there you go, right? I've got all the tricks to sort out. I'm blocked again. Let's go 10. That's an 8. Can I go 10? Now, that is not how the sinus is going to be reformed. We're actually going to use some gelatin paste to try to obliterate the sinus, and I'll show you what that looks like here in a moment. Now, give me the bipolar, thanks. We've got to do a little tidy up back here. So often this back edge is often heavily expanded, as you would expect in this situation. You don't want to completely take it back. There'll be some vessels in here. Let's go a Blakeslee forceps first, and then we'll go bipolar. So here, though, you are going to have a few vessels in here, and what you don't want is a whole lot of raw bone at this back edge, right? So very commonly, not just in her, but in everyone, I'll actually make a little effort to take out the bone between the mucosal edges to try to really allow this area to come together as a mucosa to mucosa apposition. I don't mind if there's a little bit of raw bone elsewhere, but I don't want it right there. It tends to crust, takes a long time to remucosize. And then that's the vessel right there, right? So you can see the vessel. We're just using a standard bipolar force. It needs to be set at 25, guys, please. Minji? 25 on the bipolar, thanks, guys. Yeah, awesome. Big wash, thanks.
And I agree with you, Richard, that sometimes when that crusts fall off, there's a risk of bleeding there, as it can open up the blood vessel behind it.
And you know what? That's why you need a bit of soft tissue there too. You know, Ashok. See how there's a bit of bone flake in there? That's got to come out. But Blakeslee, thanks. So really important not to leave little bone flakes. See that bone flake? Really important. Give me a bipolar. Got to make sure there's no like little bone flakes and things. There you go. But you don't want to. You decide you don't want to strip that area. It's really important not to strip it. Okay. Give me some patties now. So there's our maxillary sinus done, and now we'll sort out the frontal, right? So we'll pack about 5 or 6 pads in here. We've got our terrible mucus plug, as well as the intramucosal mucin, right? You saw it there live, right? You do see that sort of thing. You know, it's crazy, and that's why you've really got to make sure that you've got a cavity. Like if you just washed out the sinus with angled scopes and angled suckers, and you'd never really picked up on that, that would have been a recurrence waiting to happen. You know, you just cannot expect submucosal mucus and fungus to be extracted from the sinus cavity. I think we get away with it in rhinology so often because we give them steroids, and during the steroid period, that helps to suppress, and then their own system kicks in, and we get away with it, you know? But if you said to me when it doesn't work, they're the sort of factors that are at play. Now, we're just going to open a frontal, and this is obviously, you know, something that we've promoted, a needle point diathermy. It's just doing a thing called a Carolyn's window, and it's really nothing fancy. It's just a version of what people have already described. Let's go 10 sucker, thanks, and just suck my smoke for me. So all it is just drilling off the front wall, right? So here we are here. We're just going to mark off this little point here. And we're just at about the level of the middle turbinate attachment. Then we'll come forward here. And then we'll drop down where we see the piriform. I'll swap you for a second. Give me a wipe. Now, Jared, I might get you to help me out here, Jared. We don't have enough head extension, so I might get you to take out the head ring here in a second. So you can see the piriform, guys? Then you're going to drop down right on the piriform to about the midpoint of the middle meatus. You don't need to be any lower than that. Now, if you've got a little funny swell body and things, you can always just shave it, but it's important to have a septal surgery if it's not straight up there. So Jared's just going to take the head ring out. Our patient's just slipped a little bit. We had them in a really head extended position, and it's really important to do that. If you're going to work with near 0 degree scopes, you have to have the patient in really quite a head extended position. And so otherwise your instruments are hitting the chest all the time. Very annoying. Okay, so here we go here. So it's a bit like a big DCR flap, right? Massive DCR flap, except it's based inferiorly. And I used to do this with little mini flaps. And then Ashok, one day I had Brad Woodworth was at our sinus course as an invited guest, and he just said, "Look, Richard, why don't you just take it all the way forward and make it inferiorly based?" And so I did what Brad suggested, and I actually even took it. I said, "Why even take it halfway towards the piriform? Let's just take it all the way to the piriform." And you know what? Ever since then, it heals much better. The bigger you make the flap, like in many other places in the body where you make flaps, if you just make it big, it actually heals better. It gets less venous congestion. It's got better blood supply, and it just totally clears the area, ready for you to drill. Put the drill on, thanks. Now, the nice part about doing this is that we're going to now find our anatomy here. Now, if you wanted to, like say you were missing a middle turbinate and you wanted to do this technique, Ashok, you can always go down here and find the first olfactory neurone if you wanted to.
Yes.
And we'll see it's coming up almost. There it is there, right? Can you see it? The fascicle's going in?
Yeah.
Yeah, so I mean, that's how we described, when doing Lothrops about always finding the, the skull, some sort of landmark for the skull base, Now, so once you've got that, I've got like the world's, I think I've got some tissue stuck around my neck, Lenny. Can you see that? If I give it to you, you're able to get rid of it. It's sort of creating, we call it the whippersnipper approach. It's where you, big wash then while we're waiting. It's where you get a little bit of soft tissue around the neck of your drill. Weed whacker if you're an American. What do you call it? We call it a line trimmer. What do British people call that garden device used to trim the edges? Line trimmer, yeah. You get a line trimmer effect. So you can't have the line trimmer effect going on. It beats up all the water and irrigation. So what we're going to do now is just a version of what PJ used to talk about doing, taking a bit of bone. I love Jim Palmer. Jim Palmer had described the technique of just removing the whole anterior face of the Agenasi, and he used to be really aggressive with the kerosene, really come out as laterally as he possibly could. And just get the stylet ready because I'll block it up here. That's all right. We're not blocked yet. Now, down here, the first landmark you'll find is a bit of periosteum of the nasolacrimal sac, obviously. And it's quite amazing, the bone here is very different for different people. And even in one person, it can be very different. And the whole thing is designed to give you like a really nice, clear view of... Unblocked, thanks. We're just going to unblock it. The line trim. Yep, thank you. Thank you very much. Very good. It's to give you a nice 0 degree view. Now, it's not just about doing the frontal sinus this way. It's also about leaving behind a sinus cavity that's really easily managed. Now, I look at the scans, and I actually think you could probably get away with anything here because I'm not convinced there's fungal elements in the frontal sinus. But you know what? Just like we did the maxillary sinus, Ashok, if there was fungus in the frontal sinus, we would not have much success with a little angled tiny opening, you know? It'd be the same as doing an antrostomy on that maxillary sinus, right? Would be really hard to remove, hard to see it. You wouldn't be sure whether you got it all. Blocked. Yeah, don't clamp the sucker anymore now for me, thanks. Just leave it down there.
Richard, you're flattening the bone on a quite wider front, correct?
Yeah. So that's what I'm doing. I'm saucerizing it.
Yeah.
Yeah, and you can see. I don't know if you can see. Just have a stylet ready, Winnie. Lenny, it just got blocked again. Leave the sucker where I left it last time. Thanks. Yeah. No, just leave it for me. Yeah, and just don't fiddle with it when I put it down. And we'll leave it open now. So here, can you see this? Can you see this white structure here? There it is.
Yes.
There. Yeah. That's your periosteum, right?
Yes.
That there is your nasolacrimal. That over there is your first olfactory neuron. So you know, just leave the sucker, please, Lenny. Yeah, it's good. That this area here, we sometimes refer to in Lothrop drilling as called Ritter's triangle. It's this triangular bone that's in front of the frontal recess. And although I've been trying to drill with my drill with the side of it for most of the time, at this point now you do start to drill a little bit with the pole. And when you drill with the pole or the burr, you do block it a few times. You just have to have your assistant, Lenny's here, she's got a stylet ready to go. And when it blocks up, she'll give me a big wash so I can wash the field, and then she'll unblock the sucker. And then we'll just do that, and you'll see it doesn't take long here to develop. So you can see here we're in front of the frontal recess still, this triangular bone, we've got periosteum there. We know where the first olfactory neuron is. And as you can see, I'm blocked. And that's what happens a little bit when you start drilling with the pole of your burr. And you'll see in a heartbeat here, we'll take off this. I don't always find the first olfactory neuron. That's optional, guys. If you can always put it back. Leave the sucker down there. But if you think about where we are, and I think for surgeons who are really, most of their surgical orientation is about finding the sinus cavity, it is uncomfortable to do this for the first time because you really need to find the anatomy. You know, you have to understand where the periosteum is, where the middle turb or the first olfactory neuron is, and you need to understand that you're just in front of the frontal recess.
So for your draft trees or the Lothrops, do you follow the same technique but on the both sides, correct?
Yeah, 100%. Yeah. It's almost like the same principles, Ashok. And sorry, I didn't get the introduction to your guest commentator.
Oh, so sorry. She's Louise Meliak. She's a consultant. She's a rhinologist, skull-based surgeon. She was in Glasgow, just moved to Bath in the UK.
Yeah, Louise, is it?
Louise, yes. Louise.
Nice to meet you. I don't think we've met Louise, so.
No, we haven't.
Yeah, so look, so you just and you can imagine where I am now. As a surgeon, I'm in front of the frontal recess. There's my frontal recess behind me. I'm actually medial to this area, and this is the frontal beak, you know. Now, when you see this finish, you'll think, oh my gosh, that's an amazing opening. But the reality is it's not really, right? It's actually still a very limited opening into the frontal sinus, and it's great for this sort of thing if you just want to wash out a sinus cavity. But because it's in a tall, vertical corridor, it's not a very good approach to do tumors and other things in the frontal sinus. So it's not as if this is a replacement for a Lothrop, you know. You know, because you're so vertically limited between, you know, sort of media laterally, your ability to reach laterally is very limited, you know. So I'm blocked in. You can see my sinus about to open up. Yep, let's go. Almost there. And we're almost there. And then, can you see the nice part about this, though, Louise, is that I love opening up the posterior ethmoid and sphenoid to find the skull base, but you actually don't need to if you're doing something like this. You know, you can actually... Yeah, I mean, I do it in a heartbeat. And I would say to any surgeon, if you're not sure where you are, you don't know where the skull base is, just, you know, always open up the sphenoid, find the skull base, you know, make sure you understand where the roof of the ethmoid is, you know, if there's any sort of ambiguity. But the actual anatomy you need to do this type of Carolyn's window or sort of unilateral drill out is actually just all here with you anteriorly. You don't need to necessarily find it, you know.
I think that, you know, once you've found your first olfactory neuron, you know, I think you know your posterior limit, don't you? And then you know anterior to that you're safe.
Well, the nice part about doing any sort of drilling from what we call outside in, and this is why we promoted it in Lothrop, is that it's really safe. You're always got the frontal recess or frontal sinus between you and the skull base, right? The only place you don't have it is right in the midline.
Yeah.
So right in the midline, you can see I'm getting that blue lining now. Right in the midline, of course, you've got your first olfactory neuron and the forward projection of the olfactory groove. So in that area there, that's where you might get into the skull base, especially if you were missing anatomy, like middle turbinates and things like that. So we almost always either stay entirely lateral to the middle turbinate if we're drilling, and if we are going to sneak across the midline, like I have a little bit, it's actually one of the reasons why I found the first olfactory neuron. I didn't find it just to show you guys. I wanted to know what was my depth. And you can imagine, that's frontal recess mucosa there. Here's frontal recess mucosa. And I've got a little bit of a bridge here left over. Can you see that?
Yes.
So we'll get that up. And it's like, you know, I don't do anything else in sinus work, but I can always remember I've got some fantastic ear colleagues, and they used to do canalplasty, and I used to always be impressed how in a canalplasty, because in Australia we have lots of exostosis, they would open up the canal, and at the very end of the procedure you would see the epithelium, you know, and they'd flick it out. And I sort of feel like that's what this is like a little bit. It's a bit like a canalplasty. You drill with, it seems like solid bone for ages, and then all of a sudden you're into the frontal sinus and the whole thing's open and you're done. And the nice part about it is you saw how inflamed everything is. When you do this sort of surgery, there's our frontal sinus. You open it up maximally. Is that? I'm thinking that is that a little? That's like a little lip, isn't it? I have to have a look. And you see almost through here, right? It's so thin. I've left it so thin. I'm going to come back with hand instruments here. Yeah, here. And see, I've got a little lip here. You know, look how this little lip is coming forward. That'd be, you know, nigh impossible through a 70-degree to get rid of, right? But look how quickly you can just get rid of it now, right? We don't like the lip. We can maybe even open up to the other side a little bit, which I'm going to have to do here. Inner sinus septum slightly on my side, so I'm not going to leave it. I'm going to open everything up so I maximize the opening that I've created. I'm blocked again. Big wash, thanks. And we're almost there, and we're in a moment. I'll just do a little bit more drilling, and then we'll put our shaver on, and we'll turn our suction down when we put our shaver on. Not yet, though. So can you see that, guys? Frontal sinus, contralateral side. But you don't want to leave bone, right? Here, this is an opportunity where we can drill more and expose less, right? So we will intentionally drill to remove raw bone. So by opening it all up, Can you see that?
Yes.
And I do like sometimes the baby Hoseman here just to reach around the corner. She might, yeah, I can see Linny's got it already. She knows us too well. You haven't lost your touch, Linny. You remember it. Our senior nursing scrub has joined us today. She's on admin duty most of the time, but she remembers. Here we go. So really, I mean, it's really the contractual side opening now, right? But it just means, can you see how by drilling more, I've exposed less bone? Can you get that concept? And that's so important, I think, when you do this surgery. I think some people do it from inside out, and they've spent 2 hours drilling. They're just so exhausted and tired at the end of the drilling of that little bit of bone that they just, you know, they're just thankful that they've found the sinus and open it is. You know, when in fact, actually, you really need to get in there quickly and then spend most of your time finessing it and getting the shape and everything else perfect. Liddy, did we get some surgery flow? Yeah, fantastic. Now, I'll take 2 silastic sheets and I'll get Peter Lee to make a 3/4 spacer, thanks. And I'll take 1 pure region here at the end. Let's do a 3/4 spacer, single spacer, 3/4. And you can see I'm just drilling the intersinus partition. And
Richard, you can see that how the mucosa differs with the right and the left.
Yeah.
The left, it is entirely normal mucosa. You can see the edematous
it's all inflamed, right. Yeah. Let's go to shaver. Thanks, Lenny. Now, so let's I'll get a wash on a stick. But let's have a look at that, right? Because I don't think there's fungal elements up there. Louise and Ashok, I think it's...
Yeah.
I think it's just
quite clear.
It's a secondarily obstructed sinus, probably. But you know what? To me, it's heavily inflamed and could become AFS. So look at that. That's a bit of mucostasis. That's AFS waiting to happen. That's how AFS starts. You get mucostasis. All you need is a bit of fungal elements up here, and then away you go. Okay, so let's go now to. We've got our shaver back on. Let's go down on the suction, guys, to 120. Let's go kerosene up, thanks. Yeah. And so here now, we'll just take off the front wall, right? Remember I said to you, I've been leaving the front wall to do here. And so this is why in an outside-in approach, you can leave the delicate frontal sinus mucosa, and you're almost working out of the field here. Can you see how we're, I've got her head really extended, so my kerosene's trying not to hit her chest too much, because you can imagine the shape of a kerosene handle. Yeah, that'll do. And suction's down, guys, is it? Thank you. Thank you. Now, this Ashok is the joy of Carolyn's window that you then get to do. You get to do your frontal recess surgery with a quad cut. This is why I love it. Not sitting there with articulating giraffes and everything else. And when you do it with a quad cut like this, almost slightly staggered out of the lining like this, it's just easy to do. It's simple. You preserve the mucosa. You can chase all the partitions and get it perfect. Anterior mortal arteries in the skull base, so we don't have to worry about it. That was right, Peter Lee, wasn't it? Mostly. It's not exactly. It's not sitting out. There's a little ridge here.
It's a lovely opening.
Mm-hmm. You get such a clear view of all the cells, don't you? Till you've opened everything up.
It's just like doing an ethmoid cavity, Louise. Yeah. How easy is that? And we call it running the ridge. If you said to me, what am I doing? I run the ridge. I follow the ridge of this following up and follow it from we want to see it go from ethmoid across to the skull base. You can see there's a little lip here. Why is there a lip? There has to be a little cell or something in here. It's not a big cell, just a little one, right? There you go. Okay, and I don't like this. That looks ugly. Give me a drill, thanks. And you see this mass movement, guys, down here? See that? When you see that mass movement, you know it's on the orbit. We're going to drill. See this little shelf? I hate that. That looks terrible, right? It's going to get in my way and prevent us giving a nice healed cavity. We can probably put our mucosal flat back now. And it gives you, I'm sure, Ashok and Louise, you've done cases in your lifetime where it was just such an easy case. The anatomy was such that there was a wide, pneumatized agonasi, the middle meatus was giant, and you just sort of think, God, I wish all cases could be like that. When you do a Carolyn's window, that's what you're doing. You're converting your unfavorable anatomy into a standard look every time. And everyone just then becomes the same. There you go. There's that little pocket, right? We'll open that puppy up. Okay. Now give me a wash and a stick. And now we're going to close. And I'll show you. The closing's important, right? Because, it's not like taking a submandibular gland out. We're here to create an endpoint for our surgery, right? We want it to be this healthy cavity it's going to be wash-outable, irrigatable by the patient so that because right now this mucociliary function ain't working very well. And so I just put a patty up here. Give me the 60-degree curette, thanks. Do you have a 60, not the 90? Yep, it's a 90. Got a 60? You got it there? If it's not there, it's usually in the standard setup, Lenny. Yep, perfect. I'm just going to put a patty up into that frontal sinus, because you know what, that frontal sinus, Louise, hasn't had any vasoconstriction. And so before we call it a winner, right, I called the maxillary sinus a winner before it wasn't, and then I looked with a 70-degree scope and there was a big plug of mucus. So one spit and twice shy, right? I'll make sure this frontal sinus looks perfect before we call it done. Now, let's pull the dressings up here, guys, because while that is just baking, you can see our fellow Peter Lee Sachs has made a spacer. There's lots of ones that are pre-made, but I still love making them out of just a Miracell tampon, and we pull that out. Let's go to the second silastic, thanks. 2 silastics, thanks. And I'm going to cut the silastics in a certain way. Do you want to hold that for us, Peter Lee? There you go, have a look on the screen. And just have it vertical, otherwise it's a bit disorientating. Straight iris, thanks. Now, I really love, you'll never regret, in my opinion, putting silicone sheets in the nose. It looks great at the end of the surgery, but 2 or 3 days from now, it'll be really inflamed and everything else. So look, I'm really a big fan of leaving silicone sheets in to make sure everything heals well. And I often make this sort of shape. You'll see why in a second. That bit ends up at the front of the nose. You need this sort of shape, and it will cover the nose. Let's coat everything in Bactroban, guys. If you said to me post-operatively, especially in AFS patients, but all patients, Staph aureus is your enemy here. Staph is the number one thing that colonizes Staph aureus or AFS patients. And I certainly go to a lot of trouble to make sure they don't get, if they are colonized, that they get decolonized in the post-operative period, and that I prevent colonization of the sinus cavity. And that's a lot of the antibiotic regimes we use in sinus, is not to prevent cellulitis or meningitis or prevent an infection. It's about decolonizing a cavity that's really traumatized. The epithelium is inflamed. It's denuded in areas. There's lots of blood around. It just creates an environment to create colonization. And so let's go the shaver on. Thanks if it's not on. I'll trim that up a little bit of that middle turbinate.
There is a question from one of the delegates, Richard, that what would you describe this cavity as in draft terms? Is it called a draft 2B or extended?
I'm so pleased someone asked that. It's called a draft 2C.
C.
And I know that's not a real draft term, but I'm sure Wolfgang would pay it, you know, if he was still with us. I met Wolfgang many times and we talked about it. And we actually refer to it as a draft 2C. It's not something new. It's actually a variation of what Wolfgang even did himself, you know. Do you think I could get that lip a little bit more? Just give me a baby Hoseman and I'll just make sure. No, I'm pretty vertical. I always want to think, can I get more? But here, guys, have a look here at the orientation. See how we can see into everything? That's the vertex of the frontal sinus, just with a 0 degree. Have you done a graph, Peter Lee? Fantastic. Okay, so big wash now. Let's put everything back together, and I'll show you how it all puts in together. And 7 minutes, Jared. So, Blakesy, still got, this is the last one, Lenny, if you want to do a patty count. I think that's the last one. Nope. Big wash again.
The field has been excellent, and you mentioned at the beginning about bradycardic anaesthetic rather than hypotensive. So what sort of numbers do you try and, if the patient can tolerate it?
Yeah.
How bradycardic?
Yeah, no, I'm so lucky. I've got the world's best sinus anaesthetist. Look at this here. So Jarrett's so good. You know, essentially, you know, I just tell him the numbers and then he makes it happen. It's amazing. And we don't go for, I actually asked Jared not to do extreme hypotension. I don't want hypotension. I actually want bradycardia, normally with a 6 in front of it. Can I get an up Blakesy, thanks?
Okay.
And or up through cut, yeah. I have an up through cut. And so a 6 is fine. It doesn't have to be 50. It doesn't have to be crazy. But then I actually say to Jared, don't make it like an excessive hypotension. Because if you've got significant hypotension, you potentially are just dilating your systemic peripheral vasculature. And that doesn't help you as a surgeon, you know. If you have a dilated field, like if anyone's operated when someone's had an anaphylactic reaction and everything dilates, it's a disaster. You can't operate. You actually want your peripheral resistance to be tight. And so this idea of having, you know, mild, like what a mean arterial pressure, Jared, what, 90, 100? 70 then, 70, sorry. And you keep your systolic around what? Yeah, 90 and 100 on the systolic and a map of 70. 59 to 65, there you go. Okay, give me the SurgiFlow, thanks. Actually, we'll do the silicon, yeah, let's do SurgiFlow first because I have to do it. Sorry, not primed, all good. So you see this area here? You know how we stripped it all, guys? So we generally make up a very thick SurgiFlow mix. You can just use Spongistan or gel foam. You don't have to use thrombin-containing one, but you know we've just got a fancy thrombin-containing version. And we fill it so that then we place then the flap over the top. And it's all about trying to obliterate that space. And so I actually intentionally want this to become obliterated. But like I said, you don't have to do that. You could just use Spongistan. But the whole idea is you're not trying to recreate the floor at the same level. You want it almost there. And you know, Ashok and Louise, I'm sure you've drilled out the silicon sheets, thanks. All the dressings, thanks. Mac and Dough, thanks. I'm sure you've drilled out a papilloma from the maxillary sinus, and where you've done extensive drilling, the whole sinus has contracted. Have you seen that, Louise?
Yes. Yeah.
So like,
Yes, definitely.
You know, it's only really channeling that sort of experience. Do we use then, you know, this idea of sort of drilling off the bone and mucosa? Now, I probably didn't need quite as big a sheet on the contralateral side, but I just made them the same because I'm used to doing it. But you can't really suture just to the septum. You've got to always suture to a little buttress on the other side. I'm sure everyone does that, don't they?
Yeah.
And then if you just suture to the septum, it just sort of eats through. And I love silicone sheets. You know what? My opinion, you know, Ashok, over the years, I think many people who've been blamed for septal perforations, suture things, it's not their surgery that's caused it, it's the patient picking and doing things at the front of their nose in the post-operative period. Now, I think as surgeons, it's not like we're not part of the equation. We probably create a slightly anesthetic or numb front of the nose from surgery, and so they don't realize the trauma they're doing. But, you know, people who get that little bilateral little crusting and things at the front of their nose on both sides in the septum, that's not some vascular thing going on. That is the patient picking. They may not realize they're doing it, but they're picking it. And over the years, I've seen that, and I have taken patients back even to theatre at 2 or 3 weeks and put silicone sheets on it, and it all heals beautifully. But if you just leave it there to crust and just tell patients to use ointment, then it eventually becomes a perforation, because they don't really, especially if you don't educate them about the fact that it's them doing it. Sometimes just finger in the nose after wiping with a tissue. Sometimes it's outright cleaning of the nose. You know, these are the sort of things that we really see that that cause problems, you know. And so that's one of the reasons my threshold for putting silicone in is so low, because it just protects my anterior septum from any problems. Now, next one we're going to do, we're almost done. So this is my next step in getting it all to heal. It's all right. Is my spacer. Now, we usually like to use then the remaining part of our local and tranexamic, because the spacer is like ridiculously hard. The rest of the local things, yep. And you can't really move it in the nose. You can't mold it. It's too stiff. Now, I don't think putting the medicine on the spacer helps, but as I sort of just douche it all, it runs into the sinus cavity. So instead of simply just sticking in saline, I use what's left over of the dressings, and you can see here in a heartbeat.
And what is that that's surrounding the Medicel pack? What have you sutured onto it?
Too long. It's too long. Sorry. It's a glove. It's a finger from a glove.
From a glove.
Oh, okay.
Yeah, 6 glove. And it just means that when you come to take it out, it doesn't stick.
It doesn't stick.
Yeah. And you know what? The nice thing about the spacer, Killian, please, is that you know the smaller one? Yeah, thanks very much. Is that when you take it out, you only need to find this little string. I'll show you this string here in a moment. And when you find the string, you then cut it and just pull it out. And it doesn't matter, Louise, if you've got heaps of crusting and blood and everything else, because when you just pull it, it all just comes. And it's an amazing, very quick debridement. And then whatever's left behind the spacer is often really moist and easy to suck out. Mm-hmm. And so it sort of makes your post-operative care, really straightforward. Unlike my American colleagues, I don't get paid for post-op care. So I don't particularly want to have patients coming in for debridements all the time. Mm-hmm. I want to make that whole process as convenient for myself and for patients. So, doing that. Everyone who listens to with our American colleagues, the dynamic is different in America. People get paid for post-operative debridements in care. So give me the graph, thanks.
Yeah, we really struggle in the UK and the NHS actually trying to have regular post-op appointments for debridement. It's very difficult. We just don't have the capacity. And so how long do you leave the spacer in for? Sorry.
7 to 14 days. And I've got a couple of other tricks. You want to cut that in half? Curette, thanks. Here's my other little trick. So we never leave raw bone. The frontal curette, Lenny. And where we have any sort of raw bone, we'll cover it with a graft. So we've got a little bit of raw bone there. That's our graft. That's our inferior turbinate it's been thinned out and repurposed here, for the sake of this area. And I can't tell you enough. Like when we first started doing this, you'd think that it wouldn't make a huge amount of difference. Grafts like this take really pretty well. I would say the majority of the time, these sort of grafts take well, and I'll have the pure region here in a moment. So even if you got
Richard, what natural healing would you expect for a cavity like this? Is there any natural narrowing?
It should look perfect at 3 weeks. That's what I expect. Not 3 months of exposed bone and granulation tissue. That's what I saw when I was a trainee, especially after Lothrops. And that's why people get problems with stenosis. You get this chronic inflammatory reaction at the site of your healing. And I just wanted to have one last little look.
So you won't expect much of a natural narrowing of the opening.
Very little. And you know what? Even if you get, Ashok, a little bit of blunting at the front here, it doesn't matter. You've had the Carolyn's window, you're going to end up with you've done all your frontal sinus cavity really easily, and it'll leave you still with a giant opening. So even if you've got a tiny bit of webbing at the top, it's still a huge opening compared to what you would achieve with a angled instrumentation. And look, this is
pure region.
Yeah, pure region. I like it. I think especially behind a spacer, it works really well because patients don't wash it out. And then I'm just going to wiggle it up there, and perfect. See it, and now it's sitting across my flap and stuffed up in there, holding my grafts into place. And we're almost done, guys. I'm just going to fold that back. I just want to make sure this is tucked up. I always tuck the knots if I can behind the internal valve so that patients don't actually grab them. And then if I've got a little bit of space back here. If I've got a little bit of mucosa, I'll leave it across this area, and I'll take the Surgiflow, thanks, whatever's left of it. Cover that area, even if it's just going to act as a biologic dressing. That's another area that you don't want to have granulate and heal poorly. Can I get the dead space, thanks? And the nice part about thrombin-containing gel foam, it actually forms like within a day, it's like a little brick. I don't know if like mud. Have you ever seen that? It actually, if you've ever gone back in on someone who's had like a thrombin-containing gelatin matrix, it it really does form like a little pack, doesn't it? You got to really make an effort. It's not soft like this. It becomes very stuck together. Okay, fantastic. And then a little bit of Bactroban at the end, and we'll get our next patient who's got a fungal problem, but a mycetoma, and a much more straightforward situation. But we'll talk about very similar concepts. We'll drill open the whole face of the sphenoid, create a very big opening before we then remove the actual fungal ball. And we'll be back soon.
Thank you.
My pleasure.
Ashok, I think you might be on mute.
Yeah, so I think no further packs.
And we'll do all cameras off. Do you want to put up the next brain lab? Yeah. And we'll put up our brain lab. I'll put up the images of our next case. So we'll have those up ready to go. And we'll turn it over here is really quick, so we won't be long before we get next person up.
Yeah, sure. So we'll wait for your message. Okay.
Are there any other questions about that case, Ashok? For me, a big one is getting her allergy right. And it not necessarily giving her fungal immunotherapy, but she's just going to take dust mite immunotherapy. And in Australia, we have oral dust mite agents like Acarazax and Acdare, and they work really well. So that's what she's going to.
I think there's a question about not necessarily related to this case, but what is the place of navigation in sinus surgery, and when do you use it?
I use navigation when I've got a procedure that's very much directed by images. So if I've got an entirely intradural procedure, where I'm coming externally on a trajectory towards something, that's when I think image guidance is fantastic. Yeah, obviously, Ashok, from this case, you can see that we didn't use image guidance to tell us where we were. We found anatomical landmarks to really define where we were. And so I still am very much a surgeon who promotes this idea of using anatomical landmarks, because if you're a little bit starting off your career or doing something you're not used to, image guidance is great. It can help you orientate where you are. But there's no guarantee it'll work. Sparks might fly and smoke might come up from the back of the machine. And if you're sort of relying on it, then it's a real problem. How about yourself? What do you guys do? How's image guidance used in the UK?
Yeah, I think it varies. I think the way that I tend to use it is very much like that as well. So I used to use it when I started doing the draft 3s, for example, and I was building experience. I would use it just to sort of almost double check that I was where I thought I was with anatomical landmarks. But actually, as your experience builds, I've stopped using it for that. And in fact, one of the hostels that we worked in, that we did the cases in, we didn't have it, but we were quite happy doing the draft 3s because we had built up the experience with it. So yes, maybe very far lateral frontal disease, I would maybe put it on. And then obviously the skull-based cases. Yeah.
Little funny lateral mucoceles that you're trying to poke into and things. Yeah, that's often useful. Yeah. But this sort of case here, any sort of standard FES, medial maxillectomy, drilling and stuff, it's great to have in the room. It's a great teaching aid, but it's never an absolute essential item. How about you? I didn't open up the posterior ethmoid or sphenoid, and I was speaking to Ashok before about that. I said I was going to do it in a heartbeat if it was tight or I couldn't see, but I think at the end of the day it was probably the right decision. What do you think, Ashok?
Yeah, I think the scan showed all the sinuses were normal, wasn't it? So there wasn't any evidence of any infection. So if it is not, it's not to open it was probably a right thing to do.
Now,
but some people might.
That said, Ashok, I have done AFS surgery in the past where, in the process of doing the surgery, I've set off AFS in another area in the sinus cavity. So I've cleared it from one area and then it started in another. So I can happen. So, I am a little bit wary of people who would like to do everything in one go if they've got AFS. But I am always temperate about, the fact that that whole back area seems to be functioning fine and it's not expanded and it's not distorted. So we chose to leave it. We'll see how that goes. I'll get back to you.
Right. It's so individual, isn't it? Some surgeons will take a view while you're there on that side, at least particularly on the same side. If you're opening down the sinuses, why not complete the posterior tonsillectomy and sphenotomy? So it's really based on their individual philosophy as well.
Yeah, I think a lot of surgeons, it depends as well where you are in your career, because I think when you start out, you're often very aggressive and you want to do everything, and often you do too much. And then what you start to see, you maybe see complications back from having done something that perhaps you didn't need to do. So I think, reevaluating your practice as you go through your career and gain more experience is important.
That's a good point, Louise. I always say to people who have sinus cavities that are normal, even though people associate me with being a relatively comprehensive sinus surgeon, I would say when sinuses aren't broke, don't try to fix them. And I always tell the fellows that there's only one direction you can go if you have a normal sinus cavity and you open it up, and sometimes you have to, right, to find anatomy or get orientated. But when you open a normal sinus cavity up, there's only one direction you can go, and that's down, you know? And so it's such an important thing to remember. And so when people have normal sinuses and they're doing a FES on one side and they think, while I'm here, I'll do the OMC on the other side, it's such a fraught with danger. There's only a risk of making it worse, you know, unless you're really convinced there's a problem.
Yeah, absolutely.
That's a great message. It's a very clear message that if it's not broken, don't fix it.
Yeah, don't. And you know, that's not me. That's a Southern US Rod Schlosserism. It ain't broke, don't fix it. And he might have got it from Fred Kuhn, actually. So I'm not sure where it came from. So I can't claim for that saying. Yeah, so but the mucosal flaps make a huge difference. The little lateral wall flap, we call it, makes a huge difference. All of these things make a huge difference. And I can't tell you, it's doing all those things over the years have really changed my practice. And I really encourage everyone when they do sinus surgery, you know, move away from concepts of ventilation and plumbing. You know, that doesn't really marry up with our understanding of disease, and think about reshaping sinus cavities. And when you reshape them, always think about covering raw areas with silicone or grafts. Makes a big difference, in my opinion, to healing.
So over the last 10 years, Richard, what is the biggest change in your own practice as far as the frontal sinus is concerned?
Once again, I've abandoned almost all concepts of sinus disease being a ventilatory issue. So I think that plays almost no role for most patients. And, you know, so therefore that directs the type of surgery I do. And you'll see it next time. In the next case, Ashok is a great example of that, and we'll talk about it. But that's a big thing. I'm very aggressive now at modifying the local anatomy so that I can get access there. And maybe I was just a terrible 70-degree surgeon, but you know, I think doing things with 0-degree scopes, your dexterity and your ability to manipulate tissues are so much better. I think once you start working with angled cameras, you become a picker. You pick and scratch at things, and I find that very, very awkward. And then to me, the final one is just the idea of making sure that nothing is sitting in airflow. We shift something like 15 to 20,000 liters of air every day. You cannot have patients use enough saline treatments or ointments to keep it moist. It just never works. And so the idea of making patients irrigate 4, 5, 6 times a day is crazy. You're better off just covering everything with silicone sheets, grafting it, and that actually does really, really well. Like, we use silicone sheets all the time over raw areas. We graft things, we lay flaps back, and that really wasn't drilled into me, you know, when I was a trainee, but something I think's evolved in the last 10 years, you know. And things like, too, Ashok and Louise, like removing the sump of the maxillary sinus. If someone said to me, Richard, do you really need to do that? Do you really need to do it? I mean, you saw what was happening down there.
Yes.
But unfortunately for me, I'm the guy who has to sort out all the problems in Sydney, right? And a lot of the surgery is done really well in Sydney, I'd say. We train really good sinus surgeons. And so these are the sort of things that I'm left with people who have had really good surgery, but then they're still getting crusting on the floor of the maxillary sinus. You know, you've said to me, how do you sort that out? And you've got a patient who's compliant with their irrigations. Well, you need to obliterate the sump of the maxillary sinus. And these are the sort of things that I sadly have to see. And a little bit that's driven some of the changes in my practice, I would say.
Okay, thank you. That was
do you want to bring
useful.
up? Do you want to bring up the next scan, or do you want to break? How do you want to do it?
How far would you need for to prepare for the next case?
Yeah, they're cleaning the room. The next patient will be in here in a moment.
Okay, so we'll take a 5-minute break, and we'll be back. Thank you.
Fantastic.
Can I get a studio to play the information video, please? While we take a break. Thank you.
navigation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble, and that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually, and I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly for, certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Okay, thank you. I think we can go over to Sydney now. Thank you. Hello. Welcome back. So we're back with Professor Richard Harvey in Sydney. So we just had a fantastic case with the sinus surgery, showing his signature Caroline window technique, approach to the frontal sinus with the frontal draft for 2C, so wide opening. So it's a great to see how he performed the medial maxillectomy and cleared out the mucin from the sinus, which was very thick. So we will soon be joining him for the second case. So over to Sydney. Anything else you want to add, Louise?
I mean, I think what you could see from that, the field is so good, the surgery is so efficient, and Professor Harvey makes it look very easy, but it's all these small techniques that he was explaining to us that build up, these small changes that he makes with each case that give you that end result. It's great to learn all these tips and tricks and techniques to improve your visual field, to improve the efficiency of your surgery, and to improve the overall outcome as well.
Yeah, and it's interesting to see how we minimize any exposed bone. Most of the bone was either covered with the pedicle flap or then free because of the graft. Even the turbinate that was excised, he used to the advantage of covering the rest of the bone.
That's right. I think the bradycardic anaesthetic as well, because I think there is a tendency for, certainly in the UK, for hypotensive anaesthetics, but you still often have that, very bloody field, and it can be quite frustrating. So I think that's a very good point.
Correct. It's not only one thing, it's a combination of all things that together give you the good surgical fit. And of course, needless to say that the better the field is, your outcomes improve with that. So spending a little bit of time, even that reverse tendon position at 15 degree, I was so particular about having this 15 degree. Anything less than that is not really very helpful. Again, the extension, patient position, get proper access to the sinuses you're dealing with. So all these little things really mattered. And although he's a great proponent of using 0 degree endoscope for ease of access and surgery,
Mm-hmm.
he wasn't shy at picking up the 70-degree when it
That's
was
right.
really needed to check around the
Yes, it was very
corners.
useful as an
And
adjunct.
then, yeah, so you can inspect that. So we're back over to, hello, Richard. We're back over to theaters now. Can you hear us? We haven't got a sound. From what can you see here, it looks like a sphenoid, unilateral sphenoid disease with a lot of osteogenesis all around.
It's often something that we question, isn't it? When you see isolated sphenoid disease, you often, these are the things that are picked up incidentally, aren't they? And you get asked about a scan. And I think it's something that I probably would have a very low threshold for taking the patient to theatre and opening the sphenoid sinus up. You know, I've heard people talk about just leaving it, probably non-rhinologists, if they had to do an MRI scan for something else and they pick it up.
Yeah,
but,
true.
you know, I think if you have isolated sphenoid disease, it really can lead to complications further down the line.
Absolutely. And especially the surgical dilemma, it gets worse in
Right.
patients with significant comorbidities. Then you're weighing on one hand the risk of the surgery and on the other hand, risk of the disease causing any further problems. And we're talking about asymptomatic incidental finding here.
I had a case
Can you join
recently,
back
actually.
to?
Oh, sorry.
Sorry, yeah, go ahead.
No, that's fine. It was just if we had a slight delay, I shot, but we'll see if we can get back to Sydney.
Yeah. So let's connect back to Sydney. It'll be interesting to see what Richard does in this case, because often, as we find, just doing a simple sphenoidotomy may not be adequate, because it can narrow down with the recurrence. So how extensive you need to go?
Yes.
Yeah.
I wonder if you'll do a posterior septectomy and open up the sphenoid into one cavity.
Yeah, absolutely. I have over the years done my lessons in a very low threshold to consider that option, and that really gives, it's almost performing the Lothrop for frontal sinus surgery.
Yeah. I think it gives you such good access, and actually, you know, once you've done it several times, you really become much quicker at doing it and much more efficient.
Absolutely.
And in conditions that you used to have to approach externally, these lateral frontal sinus disease or pathology, that actually, if you do a Lothrop, you can get that access now out quite laterally without having to do the combined open approach, because certainly in Glasgow, I had a cohort of patients that had open approaches, and they often have quite significant neurological type pains. And it's very difficult because they do have ongoing frontal sinus pathology, but you know, you feel that it's probably not causing their pain.
Yeah, true.
And then you're in a
the
very
distinction,
difficult
yeah, where is the neurological pain, and which is the frontal, the pain due to the frontal sinus pathology. It's always hard to breakout.
Yeah.
And often that again poses a sort of decision dilemma.
They just sent a message saying Richard's out of theatre just for a few minutes. I was just going to tell you about a case recently where there was a young girl had come in with sphenoid disease, and she had a periorbital cellulitis and cavernous sinus thrombosis, and she had been fully heparinized. But actually, we took her to theatre, and this, because I think it's always this thought process, certainly in Glasgow, again, probably non-rhinologists, where once the patient had been started on treatment dose heparin, you didn't want to go in and operate on the sphenoid sinus. But again, I would have a very low threshold for that. And, went in, there was no issues with bleeding at all. And that was on somebody who was, fully heparinized for cavernous sinus thrombosis. So I don't know about you, Ashok, but I think if you've got that situation, it is vital that you open the sphenoid sinus.
Yeah. It shouldn't be too long now in Sydney. So after this case, we'll have a bit of a break, and then we'll be joining Dr. Satish Jain from Jaipur in India. So he's got quite a few interesting cases lined up, like angiofibroma, then again some revision phases. So it'll be interesting to see revision phases, because often surgical landmarks is an issue there. So how to navigate through those situations, it'll be interesting to see. And maybe some very different techniques approaching the same thing.
And it'd be interesting to see the JNA, because they deal with a huge volume of JNAs, don't they?
Yeah,
in his practice.
They have a larger tumors presenting because of late presentations. They could be quite large tumors.
Yeah. Am I right in saying as well, he tends not to embolize the patients preoperatively?
Yeah, that's what I hear. Really interesting to see what is their practice about embolization. We certainly do embolization.
That's right, yes, standard.
In most of the cases.
How were the cases earlier, Ashok, today with Puya and from the US? What cases did you see?
We had a fantastic case. I think it was a case of craniopharyngioma. And so wonderful display of anatomy. Initially, they thought it was likely to be a papillomatous craniopharyngioma.
Okay.
And so but then on exclusion, it turned out to be a cystic lesion. It wasn't really a keratoma type of epidermoid type of tumor, and they have to aspirate it out. So they have to change the surgical strategy in between. Again, a great learning about being careful in planning your reconstruction, planning your surgery.
Yes.
They had a nasoseptal flap. And great to see how Prof. Kara raises his nasoseptal flap and really explain in details about various aspects of nasal flap, maintaining the structural support to the nose, looking after being careful about olfaction, and then again using the reverse flap to help the healing and minimize the crusting, etc. And then again, very brilliant surgical techniques, dissection around the carotid, around the optic nerve by Danny Pravedello, and we went through the tubercle and approached what then thought to be a craniopharyngioma, which turned out to be a epidermoid. And very carefully aspirated all that content of the epidermoid, so that anything left behind can cause recurrence. And then reconstruction. So they use the soft gasket technique with Duragen and some spongistrone. It was very similar to what we saw on Monday with all the battaglia, where we used the gasket technique with fasciolata and cartilage. So instead, they used the Duragen and spongistrone, and that looked like a very robust repair.
So did they find that the defect that they ended up with was smaller than they had expected because the pathology was different? Or had they opened up, was the approach as big anyway because they had planned?
Correct. I mean, in that situation and that anatomical location, that was probably the widest possible approach at the time. But once realized that dissection, because it was part of it was stuck to the hypothalamus, and then making that judgment call, that is you're likely to cause more problems and more harm,
damage. That's right, absolutely.
Than the benefit. So we stopped there.
Yeah. And how old was the patient, Ashok? Was it an adult?
Patient was an adult, 50s.
Yeah.
And that's again, Danny had a good argument that it took almost 50 years for the PCP dermat to fully to that stage.
That's right.
So in the hope that another 50 years, it will take another 50 years.
It'll be fine. The craniopharyngioma was, just I was just going to mention the craniopharyngiomas, especially the pediatric ones, the defect that you create is huge. It's very difficult to reconstruct, because everything falls back into the space. So it's very difficult to, it takes quite a bit of time to reconstruct that robustly at the end of what's often a very tiring operation.
And the other thing was with these papillomatous craniopharyngiomas, there is now shift in management strategy, and that's the message Danny really wanted to give it out, that no more they're looking at attempting a complete excision, but now it is about getting the histological diagnosis and decompressing the craniopharyngioma. And then further is the medical management, which seems to be quite promising, getting the better outcomes. So that's a good, interesting shift in management strategy now.
Good.
So for a case like this, will you use navigation?
For this case, the sphenoid case? No, I wouldn't, Ashok, no. I think you obviously study your scans, you want to know what's happening around your optic nerve, your internal carotid artery. But I think, your trajectory here for your sphenoid is straightforward. So no, I wouldn't use navigation for this. What about you?
Yeah, likewise, I wouldn't use necessarily navigation in this case. And often in the cases where you use navigation, it is on a standby. We know that it is there if really required.
What I find as a consultant with the navigation, I think you use it at the beginning when you've not got as much experience with certain operations or certain anatomy, and you really are just double checking where you are. You're not using it to know where you are. But then what I've found happening is you then set it up, but you don't use it. You know, so you go through the entire operation and you don't actually pick up the probe. And then you progress to a point where, you know, cases such as this, you're not actually even setting it up.
Sure. And what is your antibiotic strategy for the case like what Richard did? Did he give any post-operative antibiotics?
I don't think so. For the allergic fungal rhinosinusitis, the case that we've just seen, I wouldn't routinely give antibiotics.
Okay, yeah. That's mainly the management with the steroids.
Yes, yes. I think that was quite interesting what Richard was saying about 3 weeks, because I think I've maybe been a wee bit overly aggressive. I've probably been giving them for about 6 weeks, but using that sort of maybe 2 or 3 weeks of the higher dose and then tapering off. But I think he's right. You know, you want to minimise the exposure to oral steroids. So that 3-week course with 1 to 2 weeks of the higher dose up to 25 milligrams, I think sounds like a good regime.
Yes.
I think they're almost ready in Sydney. Just the patient's been anaesthetised and being prepped, and then they'll be ready to go.
Yeah.
What do you use for prep? So in a patient like this, would you prep the patient? Would you use diluted betadine or?
No, not at all. So there won't be any question, just draping the patient. Then,
Yeah.
I don't use it within the betadine. And interesting to see how he approaches the sphenoid. So whether goes to the sphenoid straight or
Yes, like a transnasal approach.
Transnasal transit point. The pituitary surgery type of approach. I think while we're waiting and nearly ready, we can play one of the informational videos. Can we play a video, please?
My name is Dr. Abib Agbatova. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant syncytial formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and syncytial formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft tube B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the Draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the Propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was noted to have minimal edema, no synechiae formation, and minimal crusting. The contour propel stents were found to be in excellent position. This was a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this was an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe may have prevented restenosis, synechiae formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no synechiae formation. There was no signs of any stenosis, and again, the contour propel stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, synechiae formation, or evidence of restenosis. The contour propel stents themselves have been degraded and/or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder, and so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour propel stent because you never know what patient is going to be prone to synechiae formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it postoperatively is that if you don't feel comfortable, or if you feel like you would like to avoid placing it in an operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess, or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrowing, their middle turbinate is somewhat lateralizing, now you have the option of placing a propel stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the propel stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neoostium. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour propel stent. Whether that's in the OR or in the in-office setting will be patient dependent.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly For me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there. And we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patient.
Have you got? No.
Hello, Richard.
Hello. You got me now?
Hi, we're back. Yes, we're back.
We're back and we're ready to go. We're scrubbed and about to start. So we're just finishing up some draping and everything else. Now, so let's put the brain lab scans up on the panel for you guys. So everyone can see that. So this is a 61-year-old lady who has a 6 to 12-month history of a retroorbital and central headache. So this is a very typical presentation for a fungal ball. And as you go down, you'll see here, like in my mind, I think there can be sometimes a bit of confusion between isolated AFS and fungal ball. Like in the last patient is a young person. Can you hear me okay?
Yes, we can, but there's a bit of an echo there.
It's a young person who's atopic and they have allergy. That's very typical for AFRS. Fungal ball, though, patients are typically in their 50s to 70s. You know, there is an association with having endodontic treatment done, you know, because we think that the endodontic treatment and probably not just the endodontic treatment, but the idea of having periapical, you know, dental disease predisposes you to having mucus stasis in the cavity, and that's why you get problems with fungal ball formation. Try not to leave me with some length here. So, so she's in her 60s, and she presented symptomatic. Now, I acknowledge that actually a lot of people with fungal ball get, I'm getting a bit of feedback. Yeah, okay, yes. No worries. I'm getting so when it comes to fungal ball, it's generally symptomatic over time. So there's been studies that have looked at longitudinal assessment and observation of patients with fungal ball. And during a period of observation, only 20% of them remained asymptomatic. Many of those who present asymptomatically become symptomatic over time. So in 70 symptomatic patients or asymptomatic patients, only 20% remained asymptomatic during a period of follow-up. So when you see someone with a fungal ball, it needs to be offered treatment. And I think this is very important because when you see it and it's asymptomatic, it's all very well to say, listen, I know it's asymptomatic, but patients need to understand, can I get a spinal needle, please? That it's likely to become symptomatic over time and that they should be offered treatment. There should be no rush to that treatment. It should be considered elective, but they should be offered treatment, in my opinion. And I don't think that always happens. I think some people think it's a condition you can watch. And I think it's a condition that's not urgent, but I don't think it's a condition that can be observed. So I think there's a difference between conditions you can observe and conditions that are just not urgent. And I think that gets confused. What's in the UK, if you're 50 and you get diagnosed with a sphenoid fungal ball, would you ever be just told it's okay to watch it? Is that what's Louise and Ashok? What happens locally?
I mean, interestingly, just talking about it, me and Louise before he joined in, and I think we both agree that we would certainly be offering the surgery to this patient. Yeah. But it's about the fungal ball. But often you come across patients who have a unilateral opacification and completely asymptomatic as an incidental finding. What would you do? And that is that kind of dilemma.
Yeah, but, I tell you what, it's like someone who has a large dental abscess, or periapical lucency. You got to tell them, listen, that tooth's not healthy. We swap to the 25. You're going to need an operation at some stage. And I think that's, just because they're asymptomatic doesn't mean you don't offer them treatment. I think being asymptomatic affects the timing of treatment, how much patients put it in their health priority and when they feel like they need to do it. But it's certainly not something that I would tell patients it's okay to watch it. Now let's have a look. Let's go now to, so on our radiology, you can see it's got the classic material in it and the classic neoosteogenesis. A big issue here, Ashok, is the lateral recess pneumatization. Fungal ball is not a disease of ventilation and mechanical blockage. It is a disease of mucostasis again. When mucostasis occurs, then it sets the scenario for fungal material to grow in the non-moving biologic material. Hey, let's go now to our endoscopic feed, guys. So I just want to show you then what we're doing here. Tell me when you've got the endoscopic feed up. You got it? Okay, so here we are now. Very sadly, I've got a septal deviation on the side of my fungal ball, which I'm going to have to manage, right? But actually, if I just work past this, I can actually see it here now. Can you see the sort of fungal material coming out of the sinus? There it is there. Can you see that? And what's notable here is that, Ashok and Louise, is the absence of an inflammatory reaction, unlike the last person. Yeah. So yes, this is an example of a fungal condition, but this is a condition of fungal colonization without sensitization. And here we are, of course, we're just in the superior meatus, and we're just going to fracture the superior meatus, so the middle turbinate's being fractured out. There you go. And we've got just a tiny bit of fungal material poking out from that area, right? Now, I'm going to do a quick septoplasty. We'll do it endoscopically. So now we talked about all the things again about preparation, right? So relative hypotension but bradycardic anesthesia, reverse Trendelenburg, systemic tranexamic acid, topical adrenaline, which is 1 in 2,000. And when I inject, even my injection, first of all, my injection is long-acting local anesthetic, not short-acting, like it's got ropivacaine in it. I don't think we should be using xylocaine in surgeries. It doesn't last long enough. I know it's conveniently mixed with adrenaline, but it's actually not ideal for patients, in my opinion. And then we even put a bit of tranexamic, 100 milligrams in a 10 ml syringe for the injection as well. I'll keep that. Now, we're just going to put some patties now, have some patties on the cheek. So, good time now to bake the back of the nose with some patties. And we'll very quickly raise a little septal flap and some mucoperichondrial flaps through a hemitransfixion. And Peter Lee, I might get you down my sum, yeah, because we'll show the team how I find the things. Now, I on my YouTube channel, Ashok and Louise, I put a little thing just for, registrars and trainees often ask, how do you find the surgical plane in these patients? It's a really straightforward thing when you learn how to do it, but when you're learning, It's actually a bit tricky, right? There's no absolute clear goal as to, you know, how you do it or what's a good sign. And so I'm going to show you just one trick that I often teach trainees to help you find the plane. Yep. I'll go artery clip. I'm just going to set up the last things. We've already done timeout, so we're good to go. So Peter Lee's going to hold the scope here. Like that. Small Killian speculum. Come right in. Yep. See if you can see on the screen. Yeah, it's always one of those ones. The view endoscopic is much better always from above. Injection. And I don't mind, I'll work around you. It's all good. So first thing I do is I put the caudal edge under tension. And then I balloon out the caudal edge with local. And so it's not just vasoconstricting, Louise, it's also tamponading it. Give me the blade. Then, with now my tamponaded front wall, I'll cut straight down. And it might blur out because of the glare. Can you see it? We scratch down. Can you see there? Now what I want to do now is I want to scratch down until I see what we call cartilage dust. And I can feel it just coming up now. Can you see that? See how there's some cartilage dust there? Mm-hmm. Give me the caudal. Now by definition, we are now below the perichondrium. If you see the cartilage dust, you have to be, right? Because once you've got, pull back for me a little bit. Once you've got the cartilage dust, you know that you have to be in the right layer. Because if you're digging out the chondroid matrix, you are by definition below the perichondrium. And you can see, without even a headlight, I can find my way in there, right? And so that's really important. And then, of course, we always must, I still believe in the superior inferior tunnels. So very quickly, you'll raise in the right plane. We'll go back down now. And you want to find the best place to orientate yourself in a endoscopic septoplasty is the sphenoid rostrum. Can you see that, guys? Louise, Ashok?
Yes, yes.
That's the rostrum. So once you find rostrum, then you can find the floor. Mm-hmm. There's your inferior tunnel now. Mm-hmm. Bring your inferior tunnel forward. And then you should be able to see where the incisive nerve and there it is there. See how they're going into that canal? Yeah.
Yes.
Yeah, so we don't want to stretch that too much. That's when patients get a bit of numbness around their teeth. I'm just going to take those out, those patties. I can feel them when I'm dissecting. Now we have to pick a point. You can see where the septum, I'm going to do the world's simplest access septoplasty here, right? So this is about where it bends, don't you agree, guys?
Mm-hmm. Yes.
Yeah, so let's just take this up here. There's our bend up the top. Let's just go back a little bit. And we're well back in the nose, right? I'm right on the bony junction here. This is mainly a bony deviation. Okay, you can see I'm straight onto the plane on the other side. And I'm a big fan of getting all the plane right. And if you don't like the position of the septum, like you can't see the dissection point, just push it away. What am I looking for? Sphenoid rostrum, right? There's my rostrum. Mm-hmm. Push it out of the way so I can get my instrument in. Let's find the floor. Almost. There's the floor. There's your inferior tunnel. And now we're good to go. Little time there. We'll call that my drainage hole then. On that side. Got to have one. And there you go. And there's your superior inferior tunnels raised. And I do like the endoscope doing them all like here. Okay, so let's take out this middle bit. Let's give me a straight iris scissor, thanks. let's go heavy mayo then, thanks. So you can see I'm right on the bone, team.
Mm-hmm.
Yeah. I love cutting it. Heavy mayo, it's a great instrument for doing that. You can do it with a chisel, obviously. And then, yes, Minji's got our big Blakesley ready to go, but I just need to make sure that this thin bone at the back is released. Just so you can see me fracturing it. You don't have to do too much here. It's really this bit that has to get off.
I think for the trainees, when they see the septoplasty being done endoscopically, it really helps them understand how to do the operation.
Yeah,
I think a lot of them struggle with it because it's often done, if it's done as a primary procedure, it's done with a headlight, and they can struggle with the concepts.
Yeah, it's super straightforward when you see it done endoscopically, isn't it?
Absolutely.
You think, oh, what's all this talk about inferior superior tunnels? It's really straightforward. And you can see up here, see how we've got still a bit of a bend up here?
Mm-hmm.
So I'm going to come in here and have a look and see if I can improve this. Give me a heavy mayo again. Give me a Blakesley, small. Give me a coddle. Where's my coddle? She's taking it. And you can see I've got a tiny little, I don't know if that's a tear. It might be if it was. Recognizing a little tear early and making sure you don't continue it. It's very important. And to me, let's have a look now. Perfect. And that's about as good as I can get an endoscopic septum. If it's a funny bulb here, the high dorsum as you get further down into the support part of the nose, you can't really get that better with an endonasal septoplasty. But you can see how important that was, because it's made this area now so much more accessible. And it's not, when I think about doing access septoplasty, it's not really about just about the time of the surgery. I'm thinking about post-op care, post-op irrigations. How are all these things going to work, for my patient? Now the next thing we're going to do, no one wants to be operating in that whole lot of mucus there, right? That's a disaster. So give me a needle point, thanks. You get the sucker in your hand. So we're going to make a little tiny flap and expose the bony rostrum. Now, normally, I just burn straight down onto the bone, but of course here, we've just taken the bone out of the posterior septum, and so I just want to put a patty in just to protect my contralateral side. I just don't want to be, just in case. Just for a second. Suction to me. Okay, needle point. I hope I haven't over-tucked that. Yeah, there you go. So you can sort of see where it's coming out of, right? So we're just gently. And I'm going to drop a flap down like this. And if I hadn't done a septoplasty, I just would have gone straight to doing this. Okay, and give me the sucker. Wipe the tip of the needle point, thanks. Now I'm going to go back and make sure that as a surgeon I've cut all the way down to the bone and everything. Perfect. Okay, give me a coddle, thanks. Put the drill on, thanks. Now, once again, I don't want to be messing around here, playing through a tiny little opening, getting all the fungus out. And the other thing too is that this is not a condition of ventilation. Fungal ball, we published a little paper, Louise, just recently, a year or two ago, where we just followed up fungal balls treated primarily by rhinologists, where they never had a prior surgery. The surgery was by a rhinologist, where the rhinologist followed them up and really made sure that everything was working and doing well. But they had to, they were compliant patients, and we made sure they were compliant, at least they told us they were compliant with post-op care and irrigations. And 20% of them on long-term follow-up had mucostasis in their sinus cavity, and a big group of them, it was symptomatic. And that's because whether the mucostasis is there at the beginning of a fungal bore condition or whether it's acquired along the way, they lose their mucociliary clearance and it ain't ever coming back for some of these patients. And so a little bit, that's in my mind when I think about what surgery am I going to be doing for them. And so the surgery that we're going to be doing for them is one that's about reshaping the sinus cavity, making sure that there's excellent access for irrigation, and where possible, there's dependent drainage under gravity. So things like the retroclival recess, I want to see all disappear. So same story here. Minji's going to get her stylet ready because very sadly, once again, like the Carolines, I'm going to start drilling where I'm using the ball of, like the pole of the drill a little bit. I don't like using the pole, obviously. When you use the pole, it's not efficient drilling, just like in temporal bone drilling. And it's always better, as you can see, when I use the equator, so much better to use the equator of the burr. Now, but you see my mucosa, I do not want to get into that yet, right? Like when we do frontal sinus surgery, I don't want to get into sinus. I want to complete my drilling, and I want to remove all the bone down to the floor of the frontal sinus, the floor of the sphenoid sinus. And you know what? I ain't going to see it on this side, right? So one of the things that I'll do is I'll intentionally go and open up the contralateral side, and immediately, Ashok, it'll give me orientation as to where I am. So we'll see here in a moment. Oh, I don't want to get in on that side. I don't want to get in. Doesn't help. Inner sinus partitions may be slightly off to this side. There you go. Intentionally gone to the contralateral side, right? Because it's going to give me my orientation here. It'll give my superlateral orientation. I'm just blocked, thanks. Leave it, leave it. And probably the biggest place I want to find first is the inferior limit. Because I know superior limit tells us where skull base and brain and everything are, but it's the inferior limit to me that is where we got to drill down to when we do this case. And you've got to remember, this bone's very, very thick. And a bit like
Sorry.
Yeah, I was going to say, just a bit like we drilled more bone and created less exposed bone in the Carolines by incorporating the intersinus partition. We'll do the same here in a second. I'm just going to get a wash. It's okay. Come back in. And what's important here is not putzing around, in my opinion, with a kerosene or a punch around the ostium, but really reshaping the sinus cavity so that we're going to be left with a lovely smooth bowl of a sinus cavity. And you know what? That's sometimes easier in some cavities than others. And it all depends on how thick the bone is, how much neoosteogenesis is formed. And this sphenoid rostrum area, I'm hoping in a moment I can, just with a heavy Blakesley, so a Tilly Hankel, I might just be able to pop out, but not for a while. And so it's no little bit of bone, right?
Yeah,
now, you were going to say something,
Yes.
Louise. What were you going to say?
Yes, sorry. I know. I've got a few questions. So
Yeah,
say you were just dealing with type 2 diffuse inflammation. How would your approach to the sphenoid sinus, for example, differ, or would it differ? Would you still be looking for as wide an opening to, ensure that there's dependent drainage? What would be your approach?
Say that again to me. In what condition? So not fungal wall. You're...
Exactly. So you've just got a patient with, diffuse type 2 inflammation, so bilateral inflammatory nasal polyps.
Yeah, so
asthma,
like some sort of type 2 eosinophilic disease.
Exactly.
Yeah, so I would normally just do a full house sphenoethmoidectomy. In patients who are going on to biologics and have bad disease, I usually trim the middle turbinate, the transverse section, so you're just leaving the sagittal part of the middle turbinate. And then I will, let me just get myself orientated here. Good. One sec, give me a Blakesley. Just want to get rid of that little bit of bone. It's a bit of bone from my septoplasty, little flake. But I will make sure, I don't normally do like a bilateral drill like this, but in just inflammatory disease, I'll just leave it, don't worry about it. I will normally just make sure that the floor is dropped down so that a straight sucker can get into the retroclival recess, but just through a unilateral approach. And to me, if you said to me, why a straight sucker in the retroclival recess? Well, anyone who's looked after patients with bad eosinophilic disease knows that over time, these patients sometimes get flares, even the ones on biologics, and they get mucus plugging. And one of the things that can really be a problem is mucus plugging in those patients. And so I like to have at least, straight instrument access into the retroclival recess. And that just means that if they ever get a mucus plug, I'm not relying on prednisone alone. I can also just in the room suction it out. I also think that optimizes their irrigation. I think we published a paper maybe about 7 or 8 years ago looking at different sphenoid openings and how that improves irrigation delivery to the sphenoid sinus. So if you make a bigger hole, you get bigger delivery there. And you can see here, like when we did the maxillary fungal, the AFS case, I'm getting to a point now where I might be able to deal with the fungus. But look here, see how I can see that we're not even at the top layer of I've opened the contralateral side, so I know that we're not even close to being near the roof yet. But coming up, here we go. Give me big wash, thanks. And oh my gosh, how simple is it going to be now to deal with this ridiculous fungal ball? So there we go. A little bit more. Drill, thanks.
How long do you follow these patients up for? So, in the
at least a year. At least a year. Yeah, at least a year. I don't call it a win until I see them back at a year with the functional sinus. And you know what you need to do as a surgeon? You've got to look into the sinus cavity. I think a lot of people do antrostomies for maxillary fungal balls, and they call it a win, but then when they look in, there's a little pool of yellow secretions in the floor of the sinus cavity. You've probably seen this, and that is not something that's been done wrong by anyone. It's not the sinus cavity open too big. It's just simply a sinus cavity that hasn't got function. It's just not clearing mucus. And it happens, it happens. Let's go bipolar, thanks. You saw here I just picked up a little branch of something. So I think now's the time. What do you think? Should we have a go at... Let's go back to the... So here you go. We've got a lovely now... It almost looks like the other case we did, right? But it's not the maxillary sinus, it's the sphenoid sinus. So we've got all this tissue here. Let's put a shaver on, thanks. And go heavy Blakesley, thanks. I'll give you a sample here. For formalin, right? Don't people send it away for micro. We don't want microbiologists getting wind of fungus somewhere in the sinuses. They'll want to put my patient on lots of big treatments. Okay, now let's go big wash, thanks. And let's go to the 12 sucker. Saying I'm having to deal with mucus again, guys. It's not... Give me a look how easy it is, Ashok.
Yeah.
Easy. Fungus just comes out. Big Blakesley. And now all we have to do, guys, is we've got to shape the sinus cavity, and I've got to have a look at our lateral recess, because the lateral recess, depending on how inflamed it is, if you can get inside the teeth for me, great. I'll pull it. Now, as opposed to AFS mucus, fungal ball mucus is something you can pull out. Don't you agree? It's got a sort of a different consistency, isn't it?
Yeah.
Like old school English fudge, you know, a little bit solid. You can grab it. Big wash. And you can see I haven't even opened the contralateral side in terms of the septal mucosa. So when this heals, it just heals like a nice big unilateral sphenoid opening, that's all. Hey guys, for closure here, 2 silicon sheets, 1 nasopore. Okay.
It's almost very similar, Richard, like the draft 2C you did for the front end.
Yeah, it's exactly the same, and same sort of concepts. Whereas the previous patient had a problem with hypersensitivity reaction to the fungus, this person, their main problem is simply just mucostasis, right? And so you're going to see it in a moment. We're going to have to really work at understanding what's happening in the lateral recess. So there's a couple of things we'll do first here, guys. So I'm going to expose, you'll see the front face here. So let's pull that back. Let's pull that back. Give me the sucker. We'll go back to the 10 sucker maybe.
If this patient did not have a lateral recess, Richard, would you still open the other side? Or that is nothing?
Oh, you know, I always open the other side because it's great for making sure that it all heals well and everything else, yeah.
Okay.
I would say, yeah, it's, you know, opening the other side is not about the lateral recess. It's about this idea that these patients, you just want to find an access. Go to the drill now. So there's a couple little things we're going to do. We're going to just drill away the intersinus partition because I don't think it helps us to have it there. Okay. Okay, so I'm not a big fan. You saw me drill away the inner sinus partition of the funnel. It only improves your access and ability to control the sinus cavity, so we will very quickly just get rid of it. Now, in some fungal balls, our current fellow, Christian Merwin, is from Zurich. You know, he's done a little project to show Ashok that actually fungal bore is more likely to occur in the smaller of the sinuses, and that very commonly they have funny little things where, like, they've got a small retroclival recess and other issues going on that probably predispose some sinuses to developing fungal bore. And you can imagine, you've probably been in the retroclival recess in some people, and you see that, you know, really, you know, tiny little clefts and pockets. I think we're out of fluid, or it's come off. Big wash while waiting. Just reconnect my irrigation. Just reconnect that. That's all. My irrigation popped off. And it's very important when you're drilling in the sinuses, do not use drills without irrigation. The reason people sometimes think that drilling a bone is worse than kerosene it is because of burning. There's no other rationale as to why that would be the case. You know, you just don't want to You don't want to burn your bone. And especially as we come up to the bit of bone that's going to become part of our final cavity. I'll put a shaver on here and we'll just give it a quick shave because we've got... Now, a little bit like the sphenoid, I don't want her to have little crusts or things in her sinus cavity. So part of me is thinking about the function, right? Let's go shaver. I'll shave that bit of bone at the top, but you can see how this has made a much smoother transition there. You know, less little pockets and spaces for things to collect. And I'm just going to get rid of some of this mucosa before we then have a look. And then we'll drill a little bit of that lateral wall just to see what's happening. There we are there. Give me the drill back. Big wash, might as well. Bit of bone dust around. Let's tidy it up. Now you can still see there might be something in the lateral recess, the drill please. But we're going to now drill the last bit. See this front face of the sphenoid here? Like this would be a thing that we would very commonly drill in pituitary surgery, you know, this wall here. Because, you know, when pituitary operations, you really want access. And you'll come across a little vessel here called the palato-vaginal, or what's another term for it? Parapharyngeal. That's another option for it. It's a branch that comes off the Vidian artery.
Mm-hmm. Yeah.
And it's in a bony canal, and we'll see it here in a moment. It's not the septal branch off my flap. That's even more far forward than where we are.
Yeah. It can be sometimes one of the branches contributing to the blood supply to JNAs and all.
Exactly. It comes off a little right angle to the Vidian canal.
Mm-hmm. Yes.
Yeah, and you'll often pick it up when you're drilling this bit of bone, and it's totally fine. Okay, I've got it. There it is. Okay, see it bleeding? On cue. Okay, give me, I'll just drill a little bit more here. Get the bipolar ready, thanks. Okay, I'm gonna bipolar this, and then we'll have the big wash, thanks. Where is it? Down here? There it is. Okay, big wash. Have a sponge to me, just so I don't get wet. Okay, we're going to wash in a stick then. Just make sure we've got hemostasis. We've got beautiful hemostasis, looks good. And you can see I've intentionally kept that wall of mucosa, and I'll show you what we do with it here at the end. A bit of bone dust and things around. Give me another wash, thanks. And actually, I think we've got a little bit of bleeding just from down here. There's maybe the other branch, the other end of it. There you go, give me the bipolar, right? Look at that, diabolical, bit of back bleeding. Okay. Yeah, so you can see I use a lot of these bulb syringes in my cases. Just a great way of very quickly getting mucosa out. Okay, you can see, look, I told you.
Yes.
This is why you come and see a rhinologist for your fungal ball, right? Okay, here we go. Give me the wash on a stick. And if you hadn't made the effort to look, the long curve one, you wouldn't have seen it, Ashok.
Yeah, absolutely.
Give me the one with a short right angle. Let's try that one. Now, I was just talking to Peter Lee Sachs, who's our fellow, and I said, see that? Well, look at all that fungus come out. I said, one of the problems here with lateral recesses is that it looks like it's not a bad looking lateral recess on the image, but the bone's thickened, that narrows it down, then the lining's thickened, that narrows it down, and essentially, for the most part, it's a completely occluded pocket. Now, okay, so if you say to me, what do we do? We're going to do something very similar. Now, look, I wouldn't be against, like if this is not your area, you're not used to being in the sphenoid all the time, you could just end the operation here and just hope the lateral recess comes good. But you go the 90 curette, thanks. But channeling the spirit of what I was talking about before, if you said to me, my practice is all about sorting these problems out, and this is where sphenoid fungal balls often fail when someone's done a really nice operation, maximally open up the sphenoid, they look on, they can't understand why the patient still has a little bit of pain, a little bit of niggling issues. Let's go Paddy again on a Blakeslee. Oh, I hope I can get that back. I'll have to get my... Let's go again. Curette. Let's go the curette, please, again. And I'll see, I might go the 61 next time, actually. I think this is just a bit too... I want to decongest now the lateral recess and see what the hell is going on out there, how big it is. And we'll get a 70-degree scope and have a look. And like I did to the sphenoid floor, we might just simply obliterate the lateral recess. 70, 60. Yeah, I think it's a better angle, yeah. I thought the 90 would work. Okay, Paddy's, let's go, keep going. And so I'm just going to pack this off for a second, guys, because you've got to remember, this is the first time this sinus cavity is going to see any vasoconstriction. And it's a good time to do it. Give me my silicone sheets, please, that we were using before. Okay, so I'm going to let that bake for a second. I'm going to very quickly make straight iris sinks. It's not arts and crafts. I'll make that same shape I did before, because I want it to come forward to protect the front of the septum from fingers and trauma. And also, the nice part about putting silicone on too, Ashok, is that you don't have to worry too much about whether you beat up the lining, putting scopes and drills and everything else back and forth. It's all dumpy. You have 70-degree scope up here, thanks. You can take that back. Fantastic. And let's go with the curve sucker now, long, thin one. Okay. And Peter Lee, actually, can I get a Metzenbaum, thanks? Give me a Blakeslee, thanks. I'm going to take a little graft here, and I'll explain it in a moment. My favorite place just to harvest in a low morbidity way is always the soft tissue tail of the turbinate. Can you see that? Can you see how taking that mucosa, I'm not even into the bone or the artery itself, and that area is right at the back of the nose, so it doesn't crust very much. And if you ever want a little bit of mucosa from somewhere, so much better just to take it from this area than, the front of the turbinate, or some people take the inferior part of the turbinate. It's just an easy way to harvest. Okay, give me a Blakeslee. And you can see it's all a tiny operation here. It's about the size of an Australian 20-cent piece. What would that be in British currency? a small procedure. Okay, let's go 70. So let's have a look at it, right? So actually, before we finish, maybe just for orientation for everyone, we should just point out where everything is. So here we are here. Lateral wall on the contralateral side. Roof is just here. I can just see it. I can see roof here, right? But I haven't gone crazy. I haven't, like in a pituitary, I'd drill all this back. It's not necessary. But I've drilled this back here, so at least there's very little sump between those two areas, right? I've drilled this down, but that's actually level with the retroclavial recess now. And if I'm to drill more here, I'm not really going to achieve more. It's not like I'm going to expose less bone, Ashok. So, you know, that is an area where I might just put a graft on. Now let's have a look. And on the frontal instruments, what do you have? Those frontal probes. Just and we better get, guys, can we get a look at that. So let's get a frontal cups, side to side forward opening, side to side opening cups. And we'll take my, remember I said I didn't think I'd get my patty out, right? That's exactly what happened. So I'm looking at this now though, guys. When I look at it, it's a big looking opening. Mm-hmm. I've got it almost flush with my floor. Yeah. I'm going to inspect it. If I think that the edema is minimal and it's an area that's likely to be washed out with a very nice wide front opening, I'm going to leave it. Because it looks too big for me to simply strip out here through a transnasal route. And actually, I think if I needed to do something here, I'd probably have to come transmaxillary, front onto it. It's such a long, deep pocket. Can you see that? Mm-hmm. And look how beyond V2 there, it disappears well beyond V2.
Yeah.
Yeah.
It looks clean, isn't it? So.
It looks acceptable. It's a bit of edema. Yeah. It's probably going to wash out, and so we're going to leave it. But if it was really thickened and the bone had narrowed it down, so that it was actually even smaller than that, I'd strip it out. But that one there, I'm not confident that I could strip that out and do a good job at it. Not through this angle. I mean, I'm looking with a 70 and it's big. So, but that's all favorable. The fact that it's big means that it's probably going to do well. Can I have the pure region now? Thanks. I will take it off this. Yeah, I'm going to put it.
So again, you're applying very similar principles to frontal sinus surgery. You're using the grafts and all that on the sphenoid.
Yeah, so you bet. You bet. And the same concepts as in the maxillary sinus when it came to function, right? So just a bit of gel, just because I scratched up the back wall there. Just make sure it's 0 degree. Let's put the other one on now. Just suck it back, the pure region, before you decant. There's a lot of dead space in that tube. And I'll go back to the 10 Fraser, thanks. And now we're going to finish up, guys. So I'll show you what we do to finish. And then I've intentionally left the septum for me to close. No one needs to watch me put a mattress suture in and some horizontals. That's... I'll do that when everyone's gone. But I will put silicone sheets on. Okay. Okay, so give me the graft. Now, when you put the grafts in, you can see I took it out as a small piece, and it's now a big flatbed. That's because my fellows very kindly thinned it out and made it a nice thin graft, something like that. And that's just great. This is going to help it heal. Give me coat the nasopore with Bactroban and soak it with some tranexamic. Let's make it happen. Bactroban first. Yep, just like we do in other cases. There you go. Now, this is one area where I don't mind Nasopore. I think Nasopore works quite well. So we've got a little graft there. We're going to fold this back. That folds over that whole area really nice. This is all just the undersurface of mucosa on the other side, Louise. So, you know, once again, we're going to have very minimal
Exposed bone.
exposed bone, yeah. And it's all going to be underneath the lovely Nasopore. And then in the back of it, when I do the pure region, I ditch what they sell it with, and I just use an 18 gauge blunt. It just works a whole lot better, in my opinion. This whole middle turbinate was never sitting in a good position because it had the septal deviation there. Give me that gel back, thanks.
That's actually a question that somebody has asked from the audience.
Yeah, what's that?
What you think is a good method to medialize the middle turbinate?
Medialize? The technique I showed you in that first case where we make those little fractures here, like this. Yeah, this one's loose. It doesn't. It's already done. Like you can see, gel's holding it open. So, and now that's it, guys. And now what I'm going to do, I don't trust myself in here, right? It looks pretty, but I've been in and out with instruments and everything else, and so I'm just going to coat it with silicone sheet. But I'm going to close the septum first. And so let me close the septum, but that's really maybe let's go 5 repeat, maybe and a single tooth. I can take any questions while I'm doing this because this is a little bit boring. No one wants to, everyone's seen suturing happening. Anything else you want to know about that case? And look, that was really straightforward, you know, Louise, in my opinion, and Ashok. We knew where we were, we maximally opened things, we made an executive decision about how to manage the lateral recess. You know, there's no extra morbidity for the patient for moving all that bone. It's only an addition for them, you know, as opposed to just someone who tried to go through the natural os and just scratched around for ages. You know, that there's no extra morbidity for the patient in just doing it. And in fact, I think with a drill, you often get rid of a lot of the thick bone and you can leave almost near mucosal to mucosal edges. You know, not quite, but almost.
Yeah, and again, like the previous case, you have left other sinuses untouched. You could have easily adopted middle enterostomy and treatment, post-treatment, then to the sphenoid, wide sphenotomy. Yeah. That was
you don't need it, do you, in this case?
Exactly.
I think if you've got a papilloma, Ashok, and it's in the sphenoid, and it involves the lateral wall of the sphenoid, I think in that situation, it's really good to open the ethmoid because it allows you to see where the orbit is anteriorly to your pathology. You can find the orbital axis and the orbital wall, but something like this, pituitary surgery, this type of surgery, you know, we open the posterior ethmoid on one side in pituitary surgery, just so we've got a place for the scope to hide. But really, when things are just sphenoid-based, I keep it really simple. Aggressive at where we are, what we need to do, and artery clip, please. And then not aggressive elsewhere. Yeah. Thank you. Nice touch.
And then post-op regime for this case in comparison to the last case?
Very similar. She'll get exactly the same anti-staph treatment, so she'll get some anti-staph antibiotics. I'm not too fussed about what people use as long as it is an anti-staph cover. And I like ones that have BD dosing, right? Because when my doctor asks me to do anything more than twice a day, I'm non-compliant. And so I pick Augmentin Duo, doxycycline, cotrimoxazole or Resprim, or Bactrim as it's sometimes called. All these are great anti-staph treatments and are all BD dosing. So I like all of those. They'd be my favorites. Anything in that zone is good. I use mupirocin ointment in the nose, BD, and they irrigate BD. So everything's like a BD regime. They just do BD everything. And I will give her some prednisone, and I'll see her at a week, and I'll probably stop her prednisone. Now, that's optional, but I think giving prednisone in her is going to reduce her edema and swelling and make it more comfortable for her. It's not really about treating the disease in her. It's about making sure that she doesn't think of me too poorly as a doctor. Okay, we're about
again, there is a question about middle turbinate. Some surgeons would consider taking the middle turbinate down, and that is for post-operative surveillance access to the area. What are your views on that?
Yeah, I don't need to. I don't need to. I think you'll see when this is all said and done, you're left with a giant cavity at the back here. You know, it really is a nice big cavity. You can easily get to it. It's not like So when we go down here, we'll have no problem seeing all this. But I will, of course, put my silicon sheet in, right? So I will make sure there's not a single adhesion in this space. You know, it's so common. I see people operating down the sphenoid. They do things in the sphenoid, and it's just a bunch of adhesions between the superior turbinate, and it is amazing, and the septum, or the middle turbinate, the septum. And it's amazing, once again, how often we get away with that. We get away with it. But, you know, in some patients, it becomes symptomatic. And so it's really just about making sure that we don't cause those. And having a silicon sheet in the nose over the next couple of weeks, patients barely notice it. They're more affected by the swelling that occurs in the nasal cavity, not by having a 0.5 millimeter sheet. And I don't think it's till about they hit the 3rd week post-op that they sort of can tell that there's even something in their nose, you know.
So what thickness sheet do you use, Richard?
0.5 mil. 0.5 mil with that little extension that comes all the way forward, and then I sew it in with a 4.0 Proline. And I just do one suture. You don't need to do more than that.
Do you use mupirocin rinses a lot?
No.
No.
No. Almost. I mean. Okay. I have to say, no. Not almost never. But Louise, we all have those patients who've had radiotherapy and they've got a non-functioning sinus cavity and occasionally get mucostasis and bacterial colonizations. Yeah. So that's the only scenario which I use medicated antibiotic irrigations. You know. And then I must say I use iodine irrigations in those patients. It works quite well. And they're patients in which you just probably have permanently impaired mucociliary clearance, and they have to use irrigation all the time. And occasionally when they, it gets away on them, they get a flare, you know. But that's it. Here we go. We'll just double check everything. Get my view up. Once again, we got lovely anesthetic conditions from my very skillful anaesthetist. You can't see anything down this side, right? It's like we were never there. Never there. Yeah. And then down this side, we've got gel and everything to heal. And hopefully a middle turbinate sits in a relatively nice place. But I don't even care if it lateralizes a little bit there. It was in a lateral position already. And I just want to make sure that all of this looks good. And look, I think it was really worth doing the septoplasty, don't you think, guys? I think I would have I would have really struggled to look after that. Say this all got really crusty and I had to pull it out. I think I would have struggled. So although I think I could have potentially worked around it, it's a benefit in the post-op period. Now that's it. I've only got one more case, which is just a septal turbinate case. So that's it. I think you've got other things on. Is there any other questions?
Yeah. No, I mean, that was wonderful. I mean, it's very good surgical principles, very consistent with in both the cases. So there's a good message there. I certainly learned about using the mucosal grafts on the sphenoid. I never used that before, and I will certainly change my practice. Yeah.
Yeah, I mean, you picked up on my philosophy, Ashok. You know,
yes.
It's exactly the same. Every sinus cavity, it's the same sort of concepts. Now, but as opposed to the AFRS case, you know, this lady's healing is more about just irrigations and making sure that mucociliary clearance returns to that sinus cavity. And if it doesn't return perfectly, that's okay. We've set it up for a bit of gravity-dependent drainage. Whereas the first patient, immunosuppression because of her hypersensitivity condition is critical, you know, and so she will be someone that I won't have her come off the oral steroid until she's normalized her lining, and then even then she'll be on oral corticosteroids. Yeah.
Okay. Great. So thank you, Richard. It was wonderful to have you, and great cases. Thoroughly enjoyed it by all of us. The
My
recording
pleasure.
of these cases will be available to watch on our channel. So I must say that the case that you performed on one of our last events is still very popular. People do get to it, and the Caroline's signature Caroline's window technique. So it's great to see that again. And thank you to your theater team. Thank you to the best sinus anesthetists in the world that you have. And also big thank you to Jonathan and Steen for making this possible. They worked really hard behind the scene, getting all the technology setup done. So thank you, everybody.
And thanks for staying up for all those in Europe and England. We appreciate it.
Yeah. Thank you. See you.
Thank you.
So, Louise, that was wonderful. It was a great little tips there, and lot to learn.
Yeah, so many learning points there, and to take away from and then apply to our own practice. Ashok, excellent.
Great, yeah.
2 fantastic cases.
Excellent. So it's now 23:30, so nearly midnight here in the UK. So we'll have a break, and then we will start again at 3 a.m. in the UK. That's where Jaipur in India, Dr. Satya Jain, he'll be starting. He's lined up for very interesting cases. So roughly around 3.5 hours. So we'll see you there. Okay. In the meantime, we'll be playing some recording of the cases that were operated over last 2 days. So if you are from convenient time zone, please or miss those cases, then you can watch them now. Thank you.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. and they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly for, certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use it a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, and especially in patients with severe polyps and samtostrial. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.